So good morning and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Lockyer and I'm the board chair. We've got a busy agenda this morning with a lot of annual reports for various activities in the trust. These are reports that we're obliged to receive, but that doesn't make them any less important, and we will give them the attention they deserve later on in the agenda. It's customary for us to start our meetings with a patient or service story. This is a way of helping us to keep our feet on the ground a bit and to make sure that all of our conversations are properly informed by the reality of life on the ground, as it were. I am really pleased this morning that we're joined by Margaret Biddles and Natalie Smith, who are social workers in the Adult Community Division. Margaret and Natalie, the floor is yours.
Hello, good morning, everybody. I'm Natalie Smith. I'm the Senior Social Worker in the Section 75 Social Care team. We are commissioned by the local authority, so we work quite closely with the local authority, and we sit outside of the community mental health teams, but again, we work very closely with those as well. So we're a standalone team. So for today's case discussion, and for purposes of confidentiality, I've changed the name of the individual that I'll be talking about. So we're going with Sarah today, and I'll be exploring some of the complexity of her needs and the challenges that were faced with multi-agency working, so between social care and health professionals. I'll touch upon the legislation that was predominantly used with this lady, the Mental Capacity Act and Supportive Protection, and hopefully we'll be able to reflect on what we learned from working with this lady. So in terms of context, Sarah was a 21-year-old living in quite a remote and rural part of Lincolnshire with her mother and her 8 pets. She has autism and a mild learning disability, along with some complex attachment issues and behaviours that are associated with obsessive compulsive disorder. Her early years prior to her living with her current mum, she experienced neglect and suspicions of sexual abuse. Mum started to contact the local learning disability team as Sarah's behaviours and neglects started to become unmanageable at home. The learning disability team spent around 2 years supporting Sarah and her mum, and this included occupational therapy assessments, communication profiles and psychiatry input. After this time, social care were then invited to join the MDT and complete assessments under the Care Act. In terms of Sarah's environment, this is best explained by how her OCD needs affected her. So when social care were invited to attend, I think it took me about 6 months for me to be able to step foot into the door, because everything is purposely placed in her house. You cannot move it. The anxiety that it causes her is to the extreme. So it was a very step-by-step process, one for her accepting me as because I'm somebody new. She doesn't like new people. That takes a very, very long time. And 2, she's watching my every move within her controlled environment, because if I disrupt anything, it's just unmanageable for her. But when she was living with mum, that frequently resulted in assaults, because mum also had to live in that environment. She had to tend for her own needs as well, and that was very difficult when you can't touch or move anything. In terms of her communication, on face value, you think she presents as though you've had a very therapeutic conversation with her. She's able to give you very rationalised answers to questions, and actually really engage in that conversation. However, she only takes about 3 or 4 words from each sentence that she's able to process. And you recognise that when you revisit conversations and she repeats it back to you when they are not in the order that was spoken about, or she's come to a different rationale, which was not discussed initially. I've recently had extra knowledge around particularly females with autism, and I think this would have helped me and the rest of the MDT greatly at the time if we had this information, because it's I think in terms of description, it's an understanding. This is very applicable to Sarah. So it's referred to as masking. So Sarah will hide behaviour that is viewed as socially unacceptable. So it might be the reason that I was never assaulted when I went into her home, because from my perspective it was viewed as unacceptable. But without me there, and with just her and her mum, that was a life that they had come to, and that was the norm of their home. She would mimic other people's social behaviour to give the impression that she fully understands her own behaviour and that of others. Forcing facial expressions like smiles, imitating eye contact during conversations, and imitating gestures. The impact of masking is the loss of executive function and abilities, struggles with self-care, intense meltdowns, unable to mask in social situations, or unable to maintain those masks in social situations, reduced memory capacity, and difficulty with speaking and forming words and sentences. Prior to my involvement, the learning disability team felt as though Sarah lacked capacity around her care and support needs, and she was supported and funded by the local CCG to access a respite placement. Whilst there, they applied for a deprivation of liberty safeguards because they felt as though she would be deprived of her liberty whilst there, which they recommended that she did have capacity, and she returned home. Thereafter, her self-neglect became extreme, and particularly her collecting. We call it collecting, and that can be from anything from leftover food to crisp packets, things that we wouldn't normally collect, and they are purposely placed in the house, and if they are moved, touched, or at least the threat of, if they are moved or touched, you get a very protective response. That amongst her 8 animals as well. So they have their own needs, they make their own mess, and again, there was very little that we could do to support that because of her anxiety and her collecting needs. Unfortunately, shortly after our social care's input or involvement, Mum very quickly passed away, meaning that Sarah was completely alone, and not supported in the way that she needed. So understandably, Sarah wanted to remain at home. This had been her home since she was a child. It was all she knew, but more so in regards to the items that were purposely placed. They were exactly where they needed to be, which for her managed her anxiety. But actually, what it does is the exact opposite. It heightens her anxiety because you can't move, you can barely breathe in the environment. When she's out of that environment, she doesn't have to think about those items that are there, so the anxiety actually reduces. Between social care and the learning disability team, we supported extensively over the winter months. She survived on food parcels. She didn't have any electricity for a little while, so there was limited heat. And obviously the animals were unintentionally neglected as well. So by this point, we felt as though we'd put in all the practical steps that were possible to try and support Sarah to make some small decisions for herself and to maintain her environment unsuccessfully. Following those principles under the Capacity Act, we've assessed her for decisions around her finances and her care and support needs, both of which we felt as though she didn't lack that capacity. And a best interest decision and meeting was made for Sarah to have a period of respite. Sarah was not willing to accept that this was a best interest decision, and again, sort of referring back to her OCD needs, she needs to be at home so she can monitor and control her environment, but actually it's just increasing her anxieties, and her well-being was really starting to become affected at this point. There were tensions between professionals. I think because of the level of self-neglect, everybody wanted what was best for Sarah. But for each professional, everyone had a different view of what that best interest was. Some felt as though she should be supported into a supported living environment because it was a more permanent decision. The respite was a short-term decision to develop her skills and independence with a view to then looking at a lesser restrictive environment. And of course, there was a thought that the decision to have this period of respite should have been taken a lot sooner. We tried to support Sarah through a sort of a graded exposure approach to respite. However, this just wasn't successful and actually had an adverse effect on her. So we applied to the Court of Protection to request permission to convey and transfer Sarah to the respite placement, and that was accepted by the court, who were happy that she'd lacked capacity, and the best interest decision was for her to have a period of respite. In terms of multidisciplinary working, we can't escape the reality of Sarah's complexities and needs, and I think we evidenced every opportunity given to Sarah to try and reduce the need for restrictive options such as a respite placement, which is a care home. So again, those tensions between professionals were continued. In terms of endings, after she was conveyed to the respite placement, we had quite a lengthy Court of Protection proceedings, finalising that Sarah was to remain at her residential setting. She was actually, her needs were a lot more complex than we ever imagined. We saw a snippet, I think, of her needs when she was in the community. She has developed and she continues to learn and enhance her independent skills within the right environment for her, which is why she's thriving at the moment. Given her passion and love for animals, she currently attends a local farm twice a week for 2.5 days, and she's learning how to look after animals because that's her passion. And finally, I guess just to say that her environment gives her these opportunities now, and she's able to focus on her own skills and her own developments than she was when she was previously at home. That's it, thank you.
Thank you, Natalie. Thank you very much indeed. I'm going to open now to colleagues for questions or comments on what we've heard.
Can I come in, Kevin? Sorry.
Yeah, well, Sharon. Yeah, okay, Sarah. Sorry, I'm being bombarded by notifications all at the same time. You go first.
Sorry, no, I'll stop then. I'll wait my turn. That's fine. Thank you.
Okay. So, Sharon, would you like to go first? Do you have a question?
Yes, thank you. Sorry, I haven't got a hand to put up, so I've had to put a question in the bar. Morning, Natalie. My question is actually about the team. That's a very interesting case, and it's a good example of service provision. But I just wondered, in terms of you talked about the risk of assault potentially for you as a staff member, and my question was just organisationally, do you feel that there is appropriate systems in place for you to be able to risk assess that, or what? How do you do that?
I think for this particular lady, is getting to know her. I think before social care came involved, the learning disability team, I'd worked with her quite extensively for 2 years. There were still limitations in relation to their input by how much she was willing to accept us. So it took a very, very long time for us to get to know her just a little bit. Mum was very protective of her and was not always forthcoming in relation to the aggression within the home, but we found out later on down the line. I think it is about getting to know somebody, especially for this lady, and how her autism and her OCD impacted on her, and actually it could be quite unpredictable. But understanding how she needed to control and manage her environment will enable us to risk assess us going into that house. It's very difficult to risk assess someone when you don't know them. So there's probably flaws in risk assessments for individuals, and especially for someone that doesn't understand how their autism impacts on them as well. So then she wouldn't be able to tell me, if you move that, you're going to make me angry. She can't tell me that. So there was a lot of second guessing, I think, in some respects, but you've got to be aware of her body language. If she's tense, then you know that you took a step too far. It's being aware of those non-verbal communication cues, and that's part of our social work skills and the MDT skills. We have to be very aware of her body language and what she's telling us. That's how we risk assess it. Did that answer your question? I've rambled a little bit.
I was just looking at whether, organisationally, we provide that kind of support and training to enable you to make that judgment, if you like, But it sounds as though what you're saying is yes.
Yeah, I think we have more information now around autism, which I think helps. And I think that training needs to be ongoing, specifically around body language, so when someone becomes tense, and noticing those cues, because that in essence is going to be your risk assessment at the time. Yeah.
Okay, thank you, Natalie.
Thank you, Sharon. I've got Jane Marshall next.
Thank you, Chair. Jane Marshall, Director of Strategy at LPFT. Thank you for the story, Natalie. I think you've got across a massive degree of complexity as well as compassionate leadership and support of Sarah. So thank you for the story. My question is about how easy you may or may not find it to work out what's available in local communities to support people like Sarah. You mentioned that Sarah was able to access a farm 2 half days a week. How easy is it for our people to find out what's available to support service users in the community?
I think that's probably more of a role for. So for this lady, she lived in a very rural area, so there wasn't anything, and where she is now, there is a lot more opportunity, but she's had the support to be able to get to this point, because if we suggested some sort of resources when she was in the community, it would never have happened because her anxiety was just too heightened. In terms of resources in general, sometimes it's talking to the right people, different organisations, different teams to know what's out there. We have the Managed Care Network booklet that we have, which is really useful. Yeah, but sometimes things aren't advertised. So it is about that. It's a little bit of both, about word of mouth, maybe your Google search, and our Managed Care Network as well.
Thank you for that response. I think there is a piece of work for us to do too, as an organisation, to make sure that our people have access, you know, in one place to what's out there. So thank you for those comments, and I'll pick that up as part of our follow-up from this board meeting. Thank you.
Jane, that feels a bit like a kind of directory of services, doesn't it? Is that what you've got in mind?
Yes, it is. I think it's exactly those kinds of enablers that allow our staff to easily access information, so that you're not searching around for things that should be readily available. Thank you.
Yeah, thanks, Jane. I've got Chris next.
Morning, morning, Natalie. Yeah, this kind of leads on from Jane's question. It's probably partly answered, really. We're just recognising the complexities of the case you talked about, and that there's a conversation really between professionals about what's the right thing to do to maximise independence in a least restrictive environment. It's just, do you think we've got the right range of options available? It sounds like this lady ended up in a residential placement, and actually that probably was a good option for her in the end. But do you feel like as a service you've got the right range of options available that you'd like to have available, or is there more to do in that area?
In terms of resources, yeah, we always need more resources, always, especially over the past couple of years. Obviously, COVID has been absolutely horrific and has shut down a lot of resources. For this particular lady, I think it's very different because it was more around how her autism and her other complex needs impacted on her, and she was in such a stuck place that despite our best efforts, we were at our limits. We'd clearly evidenced that we'd done everything that we possibly could to try and not go for that restrictive option, but in the end that's what was in her best interest. So I think if there was an abundance of resources available, I still don't think it would have impacted positively on this lady. However, for other individuals, yeah, we need lots more provisions and resources and ideas and stuff. We always do.
Yeah, brilliant. Thank you, really helpful. And just so you know, we're doing some work with the local authority around a housing strategy and looking at different ranges of supported accommodation and things, so inputs into that if you've got some ideas of what might be useful. So yeah, thank you, really helpful.
Yeah, I think supported living for our service users is very slim. We're struggling on that end, I think.
Good. Thanks, Chris. Can I just remind colleagues to introduce themselves and their role, just for the benefit of external attendees? I've got Sarah and then Ananta, and then we'll need to bring this discussion to a conclusion, if we may, please. So Sarah.
Thank you. Hi, I'm Sarah Connery. I'm Acting Chief Executive here at the Trust. So thank you very much, Natalie and Margaret. And I'm absolutely delighted that we've had a social work perspective in today's story. And it was just open to challenge, really, whether you feel as a trust that we do enough to sort of integrate the social work workforce, and whether you feel like you've got enough of a voice. I mean, this is an obviously really complicated, challenging case, and whether you feel that you've got the training. I suppose it touches on Sharon's points to be able to deal with that. So it's just open to challenge if you think there's anything else that we can do to maybe improve the experience of social work staff at the Trust. Thank you.
I think part of our role is to understand our service users' needs, how their mental health impacts on them. There's always a benefit to that MDT approach, because we all have our specialisms. I think in particular for autism that there is still a gap of knowledge, I think, for everybody, because the recent information that I'd got around masking would have helped me greatly if I knew that to begin with. And I think it would have helped any other assessor help understand her needs. And for example, and I'm not saying that somebody else's judgment is incorrect, but for when she was deemed to have capacity and was returned home to essentially squalor, yeah, I think the more information we had about how her autism impacts on her would have helped. It would have been beneficial. So I think there's still education there around autism to be had.
Thank you.
Thank you, Sarah. Ananta.
Yes, hi Natalie, and thanks for sharing Sarah's story. I'm Ananta Dave. I'm the medical director here at LPFT, and you really brought to life the complexities and the issues involved. Mine was a comment and a question. I think it was about, I suppose the questions were about how do you support yourself as a team when you deal with these complex cases, which can be quite emotionally demanding as well as place pressures on the team. So how do you all support yourselves, and how do you all reflect and support one another? And the other thing, I suppose, is other people have asked about the training and what else the Trust can do. And I was also wondering whether you feel we do enough as a Trust to support around capacity assessments, independent mental capacity advocates, etc. So just your views on that. Thank you.
Okay. So your first question was in relation to team support, how we'd support each other. There was a period where I probably had every social worker and social work assistant visiting this lady when she was in the community over the winter months. It was over Christmas time, so we were very strained because of what we needed to do for this lady. We were not going to not do it, but it was starting to take its toll a little bit. Our team, I might be biased, but our team are very supportive of each other. We make a point of having those 5 or 10 minutes chats with each other, even if it's just to vent our own frustrations, and acknowledging that we are human beings ourselves. We experience feelings and emotions like anybody else, and we experience stress. and in particular we have regular supervisions, but it's just about, it's more about checking in with other people, and particularly during this period it was so important for us just to check in with each other to see, are you all right? I know it's been a really hard day. Okay, now let's deal with that. We've got tomorrow to come, and just being very supportive of each other. Did that answer your question, that first part?
Yes.
Could you repeat the second one? I'm sorry.
The second one was about, I mean, apart from all the general points around what the trust can do to support, do you feel there's enough support or enough awareness around capacity assessments, and especially our use of advocates, independent mental capacity advocates?
I think the Capacity Act in general has some flaws, especially around the deprivation of liberty safeguards as well. There's quite a few flaws, and I'm sure you're aware that that's changing soon because of those flaws. I think there's an ongoing need to ensure that practitioners feel comfortable with using the Capacity Act, because it is daunting and the accountability is huge. Because if you deem someone to lack capacity, then you are following a best interest checklist, and you can't make those decisions in isolation. So I do think it's maybe support sessions plus maybe, I don't know, some role modelling situations, and those, just so practitioners feel comfortable.
I think, can I add in, if that's okay, around capacity? So it's Margaret Biddle's, interim service manager for section 75. I think it's a very important issue, obviously, with assessing capacity, and I would say across the board, whatever discipline staff are, you know, we are assessing capacity. Some are trained in it more than others. But I think there is more need for training across the trust, whether it's within section 75 or, you know, within social care, nursing, etc. But there is definitely a need for more training. There is good training, and there are staff that are very competent in terms of assessing capacity, but it is a very complex area and deserves the training within that. So I just wanted to add that point, if that's okay. Thank you.
Thank you.
Thank you very much, and thank you, Ananta. We're a bit pushed for time, so I do need to move on, but Di, you have a question. If it's possible for you to keep it brief, that would be great. Thank you.
Thanks, Kevin. I will keep it brief. Di Bailey, one of the non-exec directors. Natalie, I'm just interested in terms of where Sarah is now, really, given the losses that she's experienced in terms of losing mum, losing her home, notwithstanding what might have gone on in early childhood. And I'm just interested really to know what's being put in place to support her with some of that going forward, really.
So we've ensured that we've got psychology input. I think her biggest challenge at the moment is understanding how her autism impacts on her. However, she's within an environment and she's developed some really good relationships with staff. There is a very family feel to where she is at the moment. She continues with her difficult attachment issues, so she has staff that she much prefers to others. And then in a few weeks' time, when she's gotten to know this other member of staff, then they're the favourite. So it is a cycle for her. However, she's not neglected. She's supported to eat well, and keep herself safe. And her anxiety is a lot lower now than what it was. And in terms of future options, I think our aim is going to be to have a lesser restrictive environment, but that is going to be a step-by-step process for this lady. yeah, so we will be looking at step downs at some point.
Thank you. Thanks.
Thanks, Di. And thank you, Natalie and Margaret. Thanks very much for giving up your time to be with us this morning. One of the advantages or disadvantages, depending on how you look at it, of being chair in these circumstances is that all the questions I wanted to ask get asked by other people. But what I will say is if you leave this meeting and think there's something I really wanted to say and I didn't get the chance, then drop me an email or a message, because I'd be delighted to hear from you. But there's a few things I want to say. The first is thank you very much for your compassion and professionalism and for painting a really vivid picture of the kind of complexity you have to deal with on a day-to-day basis. And on behalf of the board, I want to thank you sincerely for not just what you've done with this particular case, but what I know you do every day. I just want to echo Sarah's point. It's really good to hear a voice of social work in the trust, and really value the contribution that you make, and want to make sure that we give you the voice that you deserve at board level. And my last point is something for you to go away and think about. Don't necessarily want an answer now because you've covered some of this in your responses to colleagues' questions, but if there's something, if there's anything that you think the trust, anything more the trust can do to support you in the work that you do, then please shout, and I for one will always listen.
Okay, thank you very much.
Thanks very much.
Thank you.
Thank you.
Right, we now let's move on to the routine business of the board this morning. And first to take apologies for absence. The only apologies I think we have are from Philip Jackson, Non-Executive Director, who will be joining us a little later this morning. Declarations of interest are as circulated in the pack of papers, unless anybody's got any declarations they wish to make that are either new or for the purposes just of this meeting. I shall take silence as no. Let's move on then to the minutes of the meeting on the 20th of May. Does anybody have any comments or points of accuracy on those meetings, on those minutes rather? Are people content to sign those off as an accurate record? That's great, getting lots of yeses. Thank you very much. Let's move on then to the schedule of actions, which are either complete or marked as closed. What I would propose to do for the actions that are marked as closed is just to ensure that board colleagues are happy that those actions have been closed in an acceptable way, and that we are content to remove those actions from the schedule. So I'll take that in a kind of negative way. Does anyone want to raise any questions or issues about any of the actions that are marked as closed on the update? I will take that as a no then, and we will move on to the chair's remarks. I don't have anything particularly earth-shattering to say by way of introductory remarks to this meeting, except to say a couple of things. The first is that most of my time since the last meeting has been spent continuing to get to know people in and around the trust, contributing to the further development of the ICS in Lincolnshire, and having the pleasure of wielding a real solid gold sledgehammer and starting the work on demolishing the old buildings at Norton Lee, and as the first step to helping to transform inpatient facilities in Boston, which is, I think one of the most exciting developments of the trust that's going on in the trust at the moment. It was a real pleasure to be able to do that, even if I look slightly daft in the pictures of it. I don't have anything else to add in terms of, kind of opening remarks. I will move on then, if colleagues are content, to item 1.6 on the agenda, which is a set of proposals driven by the fact that we have new non-executive directors and a change in the composition of the board, a set of proposals for chair and membership of board committees. Has anybody got any questions? I'll take that paper as read. And invite colleagues either to ask questions or comments, or to indicate that they're content with the proposals as circulated. Excellent. That appears to be agreed, so thank you very much, everyone. And we'll move on to item 2.1, Sharon, and the draft minutes of the Quality Committee held on the 15th of July.
Thank you, Chair. I'm Sharon Robson. I'm non-exec chair of the Quality Committee. And for you today, I'm just going to read out the highlights and exceptions from the last Quality Committee, which took place on the 15th of July. And the first piece of information is really good. It's about the quality improvement work. The committee received a paper outlining a trust-wide approach to quality improvement, and it's been acknowledged that quality improvement methodology has been part of our way of working now for some years, and there are a range of quality improvement initiatives that are happening within the organisation. What's been missing is an identified way of the system-wide methodology and governance around quality improvement, and the paper presented focused on a sustainable system-wide methodology which focused on planning improvement, quality control and quality assurance to provide that roadmap and enable us to deliver our quality priorities. It's a really good piece of work. We're at the beginning of that journey, and we look forward as a committee to being able to share with you as we go along that journey our focus on sustainable quality outcomes. In terms of safeguarding, we received assurance around the Devon judgment, and for those of you who are not familiar with this was the Devonshire Partnership Trust lessons learnt around personally seen and personally examined requires physical presence of the patient. The committee received full assurance that a full audit of detained patients had been undertaken. We also received the learning from deaths policy update, which was the revised policy, and this led to a debate on how else non-executives could support further independent scrutiny around learning from deaths, and the non-executives present at the committee agreed that attending the review process to look at how those reviews actually took place and observe the reviews would be a good way of moving forward to provide that additional level of scrutiny, and the medical director is progressing this work. One area which the committee continues to focus on, which has given us limited assurance in the past, is around NICE guidance. This is an area where the robustness of the governance processes around NICE has not been as we would want it as an organisation, and this has been impounded really around COVID, because over the last months NICE have continued to issue guidance, and there have been capacity issues within the trust. The executive team have got a thorough oversight of this, and there is a lock-in planned to assess the position, which is very welcomed by the committee. We've received the annual report from the Patient Safety and Experience Committee, which provided assurance that the committee had fulfilled its terms of reference. And I'd like to commend to you the work of the infection control lead. We now have a non-exec director lead for infection control with Di. There are 3 further areas which are on the agenda today, so I won't go into them in detail, but the committee have seen and reviewed the Mental Health Act annual report, the Safeguarding annual report, and the quality section of the BAF. They're the areas I wanted to share with you today, and I'll open it to questions. Thank you.
Thank you, Sharon. I mean, it's a really comprehensive report in terms of what the committee's covered and under and a high degree of assurance around all of the issues that you've mentioned. Have colleagues got any questions or comments for Sharon? And welcome, Philip. Good to have you here. No, if there are no questions, Sharon, shall we move on to the Quality Committee annual report?
Yes, thank you. So this report covers the work of the committee during 2020 to 2021, and the board's asked to receive this information and receive the assurance that the committee is meeting its delegated duties. The paper sets out on page 1 the committee's authorised responsibilities, and it identifies the 4 committees that report to the Quality Committee, with a number of internal meetings that report to those respective committees. So it outlines for you the governance framework around our Quality Committee. On page 2, the report identifies the areas of regulatory and statutory compliance that the committee focuses on in relation to clinical effectiveness, people experience, safety and clinical outcomes. I'd like to draw your attention in particular to the areas of risk scrutinised by the committee, which start at the bottom of page 2. I think board members will be in the main familiar with those areas. In terms of the Care Quality Commission, we had an inspection of our long stay and rehabilitation mental health wards in March 2020. So I believe that's Ashley House, Maple Lodge, Ferns, Wolds and Vales, but I'm sure the executives will correct me if I've got any of those wrong. In the main, we had 3 requires improvements. That's around staffing establishment, supervision, training and recovery focused intervention. And we've got 53 goods and 4 outstanding. And I think that's all the areas that I wanted to raise for you on that report today.
Thank you, Sharon. Again, it's a comprehensive report that, from my perspective, provides the board with a high level of assurance around the activities of the committee over the past year, but I'll invite colleagues to comment or ask questions. There don't appear to be any.
Okay.
So, you got off lightly, Sharon. Thank you very much.
If anybody does have any questions or anybody wants to attend the committee, they're welcome to.
Yeah, I would certainly recommend doing that. Having sat in on one committee meeting so far, I would commend attendance and to see at first hand the thoroughness with which Sharon steers consideration through the committee's agenda. So thank you, Sharon.
Thank you.
Let's move on then to item 2.3, which is you and Anne to the medical report.
Yes, thanks, Chair. Good morning, everyone. I'm Ananta Dave, Medical Director here at LPFT, and the 6-monthly Medical Directors report takes us through the various activities in the Medical Directorate, covering issues relating to workforce, recruitment, staffing, as well as medical education, both undergraduate and postgraduate, the work of the research and pharmacy teams, the Mental Health Act implementation, and other aspects of quality and safety work that the Medical Directorate contributes to. I will take the report as read. I just want to point out a few highlights. We know that it is a very challenging situation in terms of medical workforce staffing, and Lincolnshire reflects the national picture in terms of the current challenges in recruiting substantive staff, retaining staff, and also getting a good pool of locum doctors. Overall, in spite of the challenging situation, we have managed to steer a fairly steady course in terms of vacancies, recruiting to vacancies and agency spending over the last 12 months, although there have been peaks and troughs within that. The welcome news about an increase in funding in the medical establishment due to the community transformation and the crisis, the core liaison teams is also meant that we are trying to recruit to more posts. The positive news around the workforce transformation around the developmental associate specialist posts is something I would like to draw your attention to. Along with the work done around recruitment to training posts, we have 100% recruitment to core training posts, and we've increased the pool of training posts. The medical school development, which is the preparation that LPFT is doing as part of hosting medical students from the University of Lincoln Medical School. So we'll be getting them for their clinical placements from February 2022 next year. And the successful business case that was approved in May helps us to be on course for the preparations that are needed to host a much bigger pool of medical students. Similarly, in the world of research and pharmacy, we've seen that there has been, in the research world, there has been outstanding activity in terms of contributing to the urgent public research like the Siren study, as well as keeping up with our commitments to deliver research, which is funded by the National Institute of Health Research. In the pharmacy team, we have seen full recruitment to posts and about various quality improvement initiatives, which are mentioned in the report. So I appreciate it covers several aspects of the medical directorate work, but I'm happy to take any questions on and comments on specific areas. Before that, I would just like to apologize for the use of some acronyms, which I thought I had addressed, but clearly not. So at various points in the report, there are acronyms. I will point out a few, but if there are others that are not clear, please do let me know. So when on page 2, when I refer to an F1 doctor and CT post, so F1 refers to foundation. So foundation year 1 trainee, F2 is foundation year 2 trainee, and CT is a core trainee. So these are trainees who finish their foundation year and enter psychiatry and are in their initial training positions for psychiatry. There is another acronym relating to the developmental associate specialist post, which says CSER, and that stands for Certificate of Eligibility for Specialist Registration. This is a particular piece of work which staff grade and specialty doctors have to do in order to be considered for inclusion onto the GMC Specialist Register, the General Medical Council Specialist Register, which will enable them to apply for consultant posts. And that's part of the work that we're doing as part of a developmental associate specialist work. Apologies if there are other acronyms which have slipped through, and I'm happy to take any questions or comments. Thank you.
Thank you, Ananta. You know, the NHS is an acronym-rich zone, so please don't feel the need to apologise for retaining a few. Before I invite questions and comments from colleagues, it's just worth noting that the workforce issue that you rightly highlight is the trust's one of the trust's most pressing risks, and we're fully focused on that in terms of how we mitigate that risk and address those concerns. Just for the record, note that. Hugh, you have a comment.
Thank you, Chair. Hugh Howe, Non-Executive Director and Chair of the People Committee. And Anta, just to commend you on the paper, I think it's a very positive paper and forward-looking. Just to touch on the point that Kevin has made, and one that we discuss at length at People Committee, is that the recruitment of new doctors from overseas, we just need to make sure that we create the right environment locally to induct them, support them so that they become effective workers within the trust, and we look after their welfare. And I think it would be worth maybe just drawing out from you what plans we're putting in place now in order to prepare the ground for that development.
Yes, thank you, Hugh, and you make a very valid point. What we would like to do is learn from the good work that has happened in our recruitment of international trainees. So we are trying to recruit to middle grade doctor positions, that is staff grade and associate specialist and specialty grade doctors, from overseas right now, and there is a process underway. But what we have been doing for the last few years is the MTI, or the Medical Training Initiative, whereby we get trainees from abroad who work with us, and that has seen some good work happening, and that helps us to learn and use that same approach for supporting international doctors who are going to be specialist and associate specialist grades. So essentially it is about having a very robust induction process, which is over and above the routine trust induction process, which enables people who are very competent in their clinical specialties, but who are not aware of the way the NHS works and the culture and the systems here. So it enables them to get that extra time. So what we do, for example, in the medical workforce is have an extra induction for those doctors who are from overseas. We appoint supervisors or champions for those who are appointed from overseas. We ensure that there is a period when they're shadowing, for example, the first couple of weeks, or there's a flexible period when they might be observing, depending on the grade that they enter in. And also we ensure that they are not put on the on-call rota for at least a couple of months, so that they are fully aware of all the processes and systems and how to manage urgent situations before they do on-calls. When they do start on-calls, we provide them with a shadow or a mentor so that they can approach them along with the person, the consultant who is on call. And the feedback we've had from the trainees, the MTIs who have benefited from that approach, has been hugely helpful. We've also put in extra preparation sessions for those who then take exams. The membership of the Royal College of Psychiatrists, the MRC Psych exams. So we've had a very good, in fact, just last week I came to know of a very good number of MTI trainees who've passed these exams at various levels. So the extra effort that we put into it has helped trainees. We have recently used some of the monies which we got from Health Education England in order to support training, to create new videos, induction packages, training packages, etc., in order to support people from abroad. And we will continue to use that approach and collect very regular feedback as well about how these people need to be supported. Thank you.
Thanks. Very, very thorough response. Thank you very much, Ananta.
And it's worth making the point, Ananta, isn't it, that as a trust, we have a determination to welcome staff from overseas and to get that, kind of cultural and experiential transition right, whether they're medical staff, nurses, or anyone else that we might be recruiting from overseas. That we want to be, a welcoming organisation that enables those staff to give of their best and to adapt to life in the NHS. Di, next.
Thanks, Ananta. Really pleased to see on page 11 of the report the research for the Everyday Clinician programme of activities. And I think just linking that to the conversation about the staffing, I think one of the ways that we can attract staff is to really, make sure that we talk positively about our research-rich culture that we're trying to cultivate. I guess the flip side of that is making sure that where there are those opportunities, staff have the capacity to make use of them, notwithstanding the staffing challenges that we have. So I just wondered how we're monitoring the uptake of that programme and where that will get reported in future.
Yeah. Thank you, Di. Yes, indeed. I mean, our research team performs very well and actually performs very well even compared to the size of the organization, and it has developed a very good reputation. So we are trying to not only ensure that we are developing good collaborations and relationships with the University of Lincoln, for example, and our existing collaboration with the University of Nottingham, but also we are working in two ways in terms of research, or I would say three ways. One is to attract clinical academic posts in the field of medical education. So these are joint posts between LPFT and the university with a specialism of medical education. So these candidates would be contributing to the medical education of the university along with doing clinical work in the trust. And those two posts have been approved as part of the medical school business case, and we are in the process of appointing to them. As you said, it gives us more opportunities in terms of being able to attract from a diverse pool more, I suppose, pull from across the country, because there is blended working available now. But also COVID has meant that people are being more cautious about those choices, but there is an opportunity there. The other one is about joint clinical research posts. So these are posts where part of the time will be spent engaged in clinical research, and part of the time will be spent engaged in clinical activities. So those conversations are going on as part of our research development forum with the University of Lincoln. So part of it is about leadership. We do have the right leadership in the trust. Part of it is about new working towards new investments and new sources of funding. And part of it is just keeping a very close eye on our university partners. I mean, the clinical academic posts are dependent on our university partners advertising them. So working very closely with the universities as well to make sure that we are on track. I would say that the environment is right. So there is the right attitude, commitment, leadership and focus at the moment. I think the recruitment process takes a while, because it's not just about recruiting into these posts, but making sure that we can retain them, and the support that is available for those who are trying to juggle clinical and research activities is right within the trust. The third pillar is about working with our multidisciplinary colleagues. I mean, we want research to be a point of attraction and recruitment, not only for medical colleagues, but across all the professional disciplines. And I think I would say that's a work in its early stages, but there is commitment, for example, working with nursing colleagues and the director of nursing to identify clinical academic posts within the nursing division and the operation division as well. So I would say that work is in the early stages, but we are very conscious of not only it aiding recruitment and retention, but improving the quality of care within the trust, and our research strategy is closely aligned to our quality strategy. The way we report it is in several mechanisms. I mean, there is the medical director report, the research activity there is a research strategy, research governance, which gets reported to quality committee. The effectiveness of it is part of now the clinical effectiveness group, which then again gets reported to quality committee. So there are various ways in which the research activity and its impact is being monitored. And that's where we are. Thank you.
Thank you, Ananta. And one last question with a free comment attached from Tim.
Thanks, Chair. So Tim Harry, recently appointed non-exec director. It's just really following up. There's a flow here from Hugh and yourself, Chair, and Di, and it's around culture. And I was fortunate enough to attend with some others on this meeting a culture intelligence training course, which I thought was absolutely brilliant. I think it needs some careful thinking about how we can use that training and apply it in the trust. So really that's my sort of comment, but I suppose it follows on with maybe comments from others in terms of picking up on the point about, if we are employing medical staff from other culture clusters, etc., how we can make sure that we take that into account.
Yes, thanks, Tim. It is an important point, and I think I would say over the last 18 months, the awareness around the need to improve our cultural sensitivity, cultural diversity, and the culture of belonging, as is mentioned in the people plan, has really been, I think people are more aware of it. It's highlighted. It's a key part of our people strategy and the deliberations of our people plan, workforce race equality standards plan, for example, the disability equality standards. So I think there are mechanisms in place, governance processes, guidance, national policies, and the focus within the system and the trust to, saying that this is an important part. I would say that, in terms of the difference that we want to make or the embedding of that, we are in the early stages, but the direction of travel is right. And we really need to make sure that it is whatever learning we have or the diversity we have within one directorate, or the medical directorate, is transferred to all other divisions and directorates within the trust, and that we learn from what has gone well as take feedback seriously and learn from what we haven't done very well. We have national metrics to guide us, for example, the Workforce Race Equality Standard, which is we know that there are many international staff who belong to various ethnic minority groups, and therefore the two are quite interlinked. Our culture of welcome to international staff and our culture of welcome to staff from diverse backgrounds and ethnicities is closely interlinked, and I think there is work to be done, especially with our focus on international recruitment. Thank you.
No, thank you very much.
Thanks, Tim. Thanks, Ananta. Jane, I've got time for one quick comment before we move on.
Thank you, Chair. Jane Marshall, Director of Strategy and People. Just to support the comment that Tim Harry made around the cultural intelligence training, linking with what Ananta's just spoken about. Over 80 leaders from across the Lincolnshire system attended that cultural intelligence training. I think we're at the very start of understanding the implications for us of truly embedding some of the learning from that training. But it's a really exciting time that we've got that many leaders who are now trained and able to start to think about how they apply that training to our work. Thank you, Kevin. Chair, sorry.
That's all right, Jane. I have a name as well. Very good comment. Thank you very much. Ananta, thank you for a really comprehensive report that just demonstrates the depth and quality of the work you and your directorate are doing. So I'm really grateful for that. Acronyms notwithstanding, thank you. You have the floor for a while, I'm afraid, Ananta. So shall we move on to item 2.4, which is the Guardian of Safe Working Annual Report. Thank you.
Thank you, Chair. So again, the Guardian of Safe Working is an integral part of our trust processes to ensure that the trainee doctors who we employ and support within this trust are enabled to work in safe conditions, that the trust respects the contract, the junior doctor contract, which came into effect 5 years ago, and that we give a positive training experience and enable them to benefit fully from what LPFT has to offer. So I take this report as read, and really this demonstrates the work that the trust has been doing in order to ensure that trainees are supported fully. So apart from the fact that there have been no significant incidents which have required notices of fines to be paid, I think the positive aspect is to see the increase in the numbers of trainees, the decrease in the gaps in the rota, a decrease in the use of locums for trainee doctors, and the continuous positive feedback and engagement we are able to have with trainees through the Junior Doctor Forum, which the Guardian of Safe Working chairs and which I attend, but also they are an integral part of our weekly postgraduate training program. I have, and regular engagement sessions with medical management team as well. So I just want to highlight that as a positive aspect, and I'm very happy to take any comments or questions. We continue to take feedback and make sure that no incident is left unmonitored. So it's all reported very regularly to the Guardian if there are any breaches or any deviance from the contract.
Thank you, Ananta. It's an informative and very positive report. I'm grateful. Thank you. Any comments or questions from colleagues? No. If not, then let's move on. Then, oh, sorry, I do have a comment, Andy.
Sorry, thank you, Chair. Andy Spring, non.
You're on mute, Andy.
Yeah, you're on mute, unfortunately, Andy.
Sorry, I've just muted myself again. Unmuted. Thanks, Ananta. I think this report provides the board with good and positive assurance about the work of if you like, the Guardian of Safe Working. Excellent. Thank you.
Thank you, Andy.
Thanks, Andy, and thank you, Ananta. Shall we move on then to item 2.5, which is the Learning from Deaths report? Thank
you, Chair. Again, I take the report as read, and this report is for information to see what it is that we do as a trust in order to ensure learning from deaths and the various processes we follow in terms of the structured judgment reviews, regular learning bulletins, the learning from incidents framework or the group that we've set up, and also the review of our learning from deaths process to now include, for example, patients who've tragically lost their lives through a combination of mental illness and alcohol and substance misuse issues. So our focus on that as a trust has translated into reviewing those patients who've died due to dual diagnosis and how we learn from them. I think what this report also offers us is the assurance that the structured judgment review process that we follow and the learning that's coming from it is positive, in the sense that those deaths which do need to be investigated through the serious incident route are accurately captured, and the ones that we investigate through structured judgment reviews highlight the good practice, but also highlight that no significant learning has been missed. So, and again, information about the numbers of deaths, how they are calculated, some of the challenges about how it can be difficult to get data, but there is very close monitoring and conversation within the system as to how we can continuously try and improve the timeliness of the data that we get around deaths. Thank you. Happy to take comments or questions.
Sorry, thank you, Ananta, again for a detailed and informative report that provides a high level of assurance around the process for review and the process for learning from tragic instances in which people lose their lives. Colleagues, are there any questions or comments for Ananta? I could see for a moment, I can see that Di is typing furiously. Question from Di.
Thanks, Kevin. Thanks, Ananta. Just really wanted to query in the report that in several places we refer to deaths remaining within the normal range. And I guess I just wanted to check that whilst we may have deaths that are within the normal range in terms of the numbers, how we flag patterns within that normal range. So perhaps if you could just say a little bit more about that, please, just in terms of assurance. Thank you.
Yes, thanks, Di. And you're right. I mean, I think, you know, when we talk of deaths, there are deaths which are deemed expected or due to natural causes or as a progression of whatever illness or condition that the person might be suffering from. And then there are unexpected deaths or avoidable deaths which are investigated in various ways. So for a time now, we've followed the statistical process chart method in order to look at a range within which a pattern which has, which we have looked at over a 12-month period and over a longer period to see what numbers of deaths we've been seeing due to various causes within the trust. And I think the comment about normal is to say that there have been no deviations from that range or that number that we have seen as part of our SPC monitoring. I think your question was about what do we do? Is it to ensure that we can make all attempts to follow or look at all the deaths?
Yeah, I think what it is that I guess what I'm saying is we may be in the normal range within numbers, but in terms of the substrata of that group, I suppose, are we seeing more deaths, related to, as we've identified, around dual diagnosis, substance misuse and mental health issues, and maybe, I guess, how do we make sure that we take account of those substrata that are happening within that overall group, those overall numbers? Yeah.
Yes, thanks for clarifying the question. We look at deaths so when we have a death which is unexpected, it is investigated either through structured judgment review process or a serious incident review process, or through, for example, what is called the leader process for those people who've died and who've had a learning disability along with other conditions. So these various processes have actually helped us to identify some of the areas, for example, around dual diagnosis. We've looked at, followed deaths due to, say, dementia or frailty, or we've looked at deaths of those who are on a care program approach, for example. Serious incidents are investigated according to the national requirement for investigating serious incidents. And, you know, as has been mentioned elsewhere, as a mental health trust, we do obviously keep a very close eye on suicide figures, because patients unfortunately die by suicide, and also people within the community. So we have seen, so based on that, for example, we know that we have not seen any change in trends or patterns officially from whatever has come out through coronial inquests, etc., or numbers of suicide, for example. But within those suicides, we have looked at how do we support males specifically, because they are more prone, they are more at risk in terms of their highest category. Middle-aged males have the highest category of risk in terms of suicide. Those with dual diagnosis, younger people who are coming through the services, where the numbers nationally are said, you know, they are showing signals of increasing, but they're still not being reported as officially high. But we know that these are the high risk groups. So for each of these groups of people, we have plans, either which is incorporated in the training or as part of the divisional review plans. You know, so for younger people, the Specialist Services Division keeps reviewing its suicide prevention policy, and also through learning. So by looking at the learning that has emerged, carer feedback, by the support through the bereaved families, you know, that the feedback that we get from them. So there are ways of identifying these patterns and continuously working to embed training, supervision, leadership and development, whether it needs specific processes, etc. So that gets constantly reviewed. And I think the governance process is through the Mortality Surveillance Committee, Quality Committee. We have suicide prevention, which is considered as part of mortality surveillance. So that's how we keep an eye on trends and what comes out from within those deaths. Thank you.
Thank you, Ananta. Thank you, Di. I think it's fair to say, isn't it, that Di's point is the detail behind Di's point is for Quality Committee to, you know, engage with and to provide onward assurance to board.
Okay, thank you.
Thank you.
Thanks, Di. Let's move on, if we may, to item 2.6. I'm going to take two further items, and if people are feeling slightly parched, I'm going to take two more items and then take a quick break for a cup of tea. So, Ananta, I think this is the final one in your run of items on the Mental Health Act annual report.
Yes, I have one report later on, but yes, in this run, it is the final one. Yeah.
You get an encore later, yes.
Yes. So the Mental Health Act annual report, again, I take that as read, and it gives an overview of the activities that the Trust has carried out over the last year in order to maintain assurance around the implementation of the Mental Health Act. So a large part of the work has been focused on the changes that have had to be made to policy, which were made nationally and which we had to implement locally. Policy that was influenced by COVID-19, whether it was to do with assessments of patients who needed to be assessed under the Mental Health Act, about how they were reviewed, and about how various renewals and reassessments were carried out under the Act. So this is to provide assurance that as a result of COVID-19, the Trust was able to quickly put in place local guidance which reflected national guidance. It responded very quickly to the change in national guidance in January following the Devon judgment, which deemed that no assessments under the Mental Health Act could be done virtually. They had to be done physically, face to face. It very quickly carried out an audit of all the patients who might have been affected, communicated openly with them, was able to modify training to reflect the needs around COVID and some of the changes which had come into the Mental Health Act and which incorporated some of the approach on least restrictive practice and on ensuring that we were able to maintain a respectful, culturally sensitive approach when dealing with patients who were detained under the Mental Health Act. And there was also a big piece of work done to introduce electronic forms into the trust, because again, this was a national exercise which was implemented locally and very ably done by the Mental Health Act team, whereby electronic forms were introduced, staff were trained, and all the staff, whether in inpatients, in the community, medical, nursing, and the social work workforce who act as AMS approved mental health practitioners, have all been on board. And we've also worked very closely with the council in order to ensure that the policies that had to be brought into place due to COVID were distributed within the system, and that we had the council on board. So it gives an overview of the numbers and the work that the trust has done in order to keep up with guidance and training. Thank you. I'm happy to take any comments or questions.
Thank you, Ananta, and thank you once again for a very detailed, comprehensive annual report, which, as you say, goes a very significant way to providing board with assurance around the Trust's meeting of its Mental Health Act responsibilities. So thank you for that. Questions or comments from colleagues? One of the disadvantages of us not having the putting your hands up function is that I can see people typing and don't know whether they're typing because they're furiously putting in a C or a Q to ask a question or something else. It makes things a little bit slower and less certain. But I don't appear to have any comments or questions, so we'll move on. Thank you very much, Ananta, and thank you for that run of reports, all of which are, first class in terms of content, depth, and comprehensiveness. So I'm really grateful. While we have a break, you might want to go and have a lie down after all of that. So thank you very much. We'll move on to item 2.7, Anita, which is yours, and that's the annual report on safeguarding and mental capacity. Thank you.
It is, thank you. So as a trust board, we are required to produce an annual safeguarding report. For those of you with an excellent memory, you'll probably be realising it isn't 12 months since we looked at last year's annual report. The annual report for last time was a little bit late coming. We'd kind of got caught up in COVID, but in terms of the time frame that it covered, it did cover the previous year. So this report coming to this board allows us to now get back on track with our annual reports. So it has been looked at in detail at Quality Committee. The report that originally went onto the list of reports, there was an error in some of the numbers, so for that I apologise, but the correct report is now in front of you. I think there's a couple of bits that I really wanted to make reference to, and that is kind of the commitment of the team and the commitment for us to maintain and high quality safeguarding kind of service to the staff and patients of LPFT, despite the ongoing pressures of a pandemic. There is no doubt that the safeguarding world has seen some very complex cases coming through. You'll notice from the report that children's referrals actually went down, so but that actually is a national picture. So with the schools being closed and with a lot of people kind of obviously in lockdown at home, we did see referrals for children take a drop. This goes up to March, but we have seen from April onwards that increase. So definitely we are seeing a change in picture and we'll be picking those up. You will see there is a new domestic abuse board that is now kind of in place in the county. So I am a member of that, and I think that really outlines the dedication and commitment around the domestic abuse agenda, which we know has become heightened during the times of COVID. And I think one of the other bits just within the report, I think it's an excellent report. It outlines the fantastic work of the team. It has been looked at in detail in Quality Committee, but I did want to just draw attention around safeguarding champions. These are 115 staff that are based out in clinical services who kind of link directly in with the safeguarding team. So that allows safeguarding practice to be kind of that. We heard earlier in the patient story about mental capacity and the additional training potentially that was required, and these safeguarding champions have a higher level of knowledge to support colleagues in those areas. So I'll take some of the comments that were made earlier in the patient story and feed that back in to some of the safeguarding champion work. But other than that, I'm happy to take comments. I think it is an excellent report that demonstrates kind of the achievements we've continued to make. There were several recommendations that were made from Quality Committee that have been put into the report, including a glossary, because like Ananta, and as you've said yourself earlier, there are so many acronyms that we just get so used to, and the glossary was a key addition to this report. But happy to take comments and questions.
Thank you, Anita. Just going to echo what you've said. It's a really thorough report that again provides a high level of assurance to the board. I'm really grateful for it. Thank you very much. It doesn't appear that there are any questions or comments from colleagues. So appreciate the work that's gone into the report, and I appreciate its thoroughness. Anita, thank you very much.
Thank you.
I'm going to propose, colleagues, that we take a break now. According to my clock, it's 10:32, so let's reconvene, if we may, at 10:45. Thanks very much.
Thank you.
Okay, it's 10:46. I'm a minute late. I'm really sorry, but I had some problems with technology. To wit, I couldn't make the kettle work. If everyone is back and ready to go, let's move on to section 3 in the agenda and item 3.1, which is the minutes of the last People Committee meeting. Hugh.
Thank you, Chair. Good morning, everyone. Hugh Howe, Non-Executive Director and Chair of the People Committee. The last meeting took place on the 10th of June, and with your permission, just go through a few of the highlights and exceptions that we captured in our report. We started our meeting with a staff story, which is part of our feature, and Alison Bartle, the ward manager for the newly established female acute inpatient ward at Ash Villa, gave us a very honest and open reflection on the setting up of the new ward. And whilst we're very proud of some of the developments and the way in which we've been able to bring patients from out of area into Lincolnshire, there were a number of challenges that she shared with us. Just to reassure colleagues on the board that executive colleagues were also present at the meeting, and lessons have been learnt and incorporated into ongoing ward developments. They're doing a great job, but I think it's also honest and open to say that there were some challenges in the early establishment of the ward. Going on to a theme which I think will dominate much of our thought and thinking over the next few years, challenges in terms of risk of recruitment and retention, we wish to bring to the board's attention the current high level of vacancies within the trust, but also some of the planned services changes that we're making are likely to generate additional challenges in terms of staff vacancies. And so as part of a challenge to counter that, the board is developing a rapid recruitment team headed by executive colleagues on a regular basis to review the system and the structures that we have in place. We looked very closely at the Equality Diversity Annual Report in terms of Workforce Race Equality Scheme and the Workforce Disability Equality Scheme. We saw some new reports brought forward in order to give greater inclusiveness and to focus more on race equality. The annual report is an item coming up that we will be looking at closely, but also to commend the work of colleagues in that area in some very thorough work being done to bring about standards to create greater equality in our workforce. Linked to that, there'll be some change arrangements coming forward that the executives are considering in terms of the governance of the staff network teams. Another area of our work was to look at the workforce matrix, and Kelly Brooks, who's the Business Intelligence Team Coordinator, gave us a very detailed and thorough look at the dashboard that we're using in order to monitor closely on a regular basis issues around people and look at our matrix to ensure that we have accurate reports. We considered and approved 2 reports that went to the Health Scrutiny Committee in its meeting in July, looking at the new pathways for children, adolescent mental health services and older adults home treatment teams. These are 2 services where we've brought about some major changes and want now to make sure that these become an integral part of the work that we do in the trust. And final point, Chair, is to reflect on the board assurance framework, where we identify the 5 key risks preventing the trust in this area meeting its strategic goals in terms of the people strategy. The BAF, the board assurance framework, has been revised. We've given it some thorough review and recommendations we've taken on board from internal audit. That has also gone back to the audit committee, which later in the meeting is reporting on the work that we've been doing. So there's cross-fertilisation and assurance being sought from a number of sources in terms of the key risks that we're facing in this area. Happy to take any questions or comments. Thank you very much, Chair.
Thank you, Hugh. Really comprehensive and helpful report. Thank you. As you know, we've got the next item on the agenda are the Race Equality and Disability Equality Scheme annual reports. So we won't we'll pick up discussion on those in a moment.
Yeah.
In the meantime, are there any questions or comments for Hugh? No?
Great.
Excellent. Thank you very much. Thanks, Hugh.
Thank you. Thank you.
And let's move on then to 3.2. And Jane, I think this is yours.
Thank you, Chair. Jane Marshall, Director of Strategy and People, here presenting the annual Equality, Diversity and Inclusion report for 2020-21, which was considered in draft by the People Committee, as Hugh Howe has just described. This report provides assurance to the Board of Directors that despite an exceptional and difficult year, we've continued to make progress on our public sector equality duties, including on the Equality Delivery System, Workforce Race Equality Standard, Workforce Disability Equality Standard and the Gender Pay Gap. And that's an excellent framework for us to assess our progress. We have had to refocus some of our attention of our equality, diversity, inclusion specialists onto work associated with supporting staff during the pandemic during the course of this year. And you'll see some examples of how we've done that throughout the report. The second part of the first part of the report looks in detail at some of the data that we have available to us that guide us on those areas where we have made improvements but need to make further improvements. The second part of the report celebrates the work of our mandated and additional staff networks and the developments that they're making in support of the equality, diversity and inclusion agenda, including making services more accessible for people in terms of reasonable adjustments to support people who identify in certain protected characteristics. Within the report on page 31, we have made progress in analysing the patient data, which is associated with how our patients who may identify with a protected characteristic or characteristics access services. And we've got more work to do in that area, but we're developing a dashboard for consideration by the Quality Committee or the board in future meetings, which looks at the impact on health inequalities for people with one or more protected characteristics. I think it's fair to say that this is a really good piece of work that reflects dedicated hard work by the team involved. But the bar is being raised on the equality, diversity, inclusion agenda, and there are significant additional expectations of us as NHS trusts, but also as a mental health trust in supporting this agenda moving forward. My colleague Tim Harry mentioned the cultural intelligence work, and we talked about the 80+ leaders across the system that have gone through that training. That's an important piece of the jigsaw as we navigate with care national expectations and match them with the local picture within Lincolnshire on equality, diversity, inclusion. That comes together quite a lot at Lincolnshire system level in the future, in terms of Lincolnshire-wide strategies where we're supporting each other to work on the equality, diversity and inclusion agenda, and also in a benchmarking exercise that we are undertaking now that will inform the People Committee in September, and that benchmarking will assess all of the expected requirements in terms of actions on the equality, diversity and inclusion agenda across all protected characteristics, but then look at the required actions as well, and that will be reported through to the People Committee. I would just like to highlight for the board's attention, whilst this is a really good reflection of our work, obviously it identifies significant challenges on this agenda that we still have to make progress on and will be focusing attention on. Those are highlighted in the cover paper, particularly on page 2. So for the workforce race equality standard, we have some significant challenges that are detailed there from feedback from what staff are saying their experience is through the annual NHS staff survey, including challenges around recruitment and shortlisting, the relative likelihood of our Black, Asian, minority ethnic staff entering formal disciplinary processes as compared with our staff who identify as being white, the percentage of our Black, Asian, minority ethnic staff experiencing harassment, bullying or abuse from patients relative to white staff, where we have made some improvements, but we still have work to do because some of the feedback we're getting from our staff in terms of what's happening is not acceptable, and we have a duty to our staff to ensure zero tolerance of that level of harassment, bullying or abuse, but also some discrimination reported from managers and team leaders, again, for our Black, Asian, minority ethnic staff who are experiencing that. For the workforce race equality standard, those actions, the so what for these metrics will come through the workforce race equality standard action plan, which we have put in place an engagement exercise with our staff networks, but also people more broadly to co-produce. That will be coming back to the People Committee at the September meeting, and with any escalation to board as appropriate. And the report that you've got identifies some of those key areas that for action that we can be getting on with in the meantime and are getting on with in the meantime in anticipation of that action plan. For the workforce disability equality standard, again on page 2, we have the areas that we're concerned about and are prioritising for specific action. And if I run through those, because this is important, the relative likelihood of non-disabled staff compared to disabled staff being appointed from shortlisting when we're recruiting, the percentage of disabled staff compared to non-disabled staff experiencing harassment, bullying or abuse from managers or other colleagues, the percentage of disabled staff compared to non-disabled staff saying that they felt pressure from their managers to come to work despite not feeling well, and the percentage of disabled staff compared to non-disabled staff saying that they are satisfied with the extent to which our organisation values their work. The other area, with permission, Chair, that I'd just like to highlight as part of this is the gender pay gap, which is identified on page 17. There is some analysis in the attached annual report, but there's a more in-depth analysis and an options appraisal paper that will be going forward to the executive team. There are some significant challenges with gender pay gap that we need to consider both as an executive but also up through the People Committee and then to board. I'll stop there. Really happy to take any challenges and questions on this. Thank you, Chair.
Thank you very much, Jane. We're asked to agree the draft report. So grateful for confirmation from colleagues, please, that we are happy to do so. On the specific actions that you've just mentioned, Jane, on page 2 of your paper, can you just outline for me very briefly what the process is for tracking progress against those actions?
Those actions are tracked through the the 2 action plans that we are required to publish as an organisation. Those go through the executive route, through staff networks, the engagement process that I've described, then to the People Committee, and those will be going to the People Committee in September, in line with our forward agenda for that committee. In addition to that, Chair, we are undertaking a review of our recruitment policies and processes on the back of a national expectation that we do an overhaul of our recruitment policies. That's due to report to the board in early 2022, and there was some bringing forward of the expectation around that at the last People Committee, so we'll be doing an interim report more sooner than that. And the final thing for me to mention is that the paper on staff networks and governance arrangements will be coming through to the Board of Directors in September, and obviously hardwiring staff networks into the governance process of the organisation and resourcing them effectively is a key part of our consideration. Thank you.
That's helpful, Jane. So in summary, the board will be cited again on progress against these key actions via reports from People Committee.
It will, yes.
Yeah, excellent. Thank you very much. I have a question from Sharon.
Hi, thank you, Jane. Very thorough report. I just wanted to ask a question about page 5, which is the equality impact assessment. And it, you could probably put me right on this, but there were 11. 10 related to COVID. There was only 1 that related to policy, strategy, tender, and that number surprised me. And I don't know whether it's how we benchmark that with previous years or relatively similar organisations, or whether they're just all lumped up in the COVID. But I thought we'd have a lot more equality impact assessments than that.
Yes, I thought the same. I think I know of that one. But you're right, I think the exceptional nature of what we were considering during the year because of COVID meant that that was that cluster, if you like, linked to the 10 items there under COVID around personal protective equipment and the impact on people who might identify as with a disability. To give further assurance to the board, I've asked for some, and the People Committee, I've asked for some trend data on those. And you'll note from the report, I think that we need to take the learning from COVID and apply that, because we were able to take rapid decisions on equality impact assessments for COVID. I think that practice is something we need to replicate across all of our areas where we need to do those equality impact assessments. Thank you, Sharon.
Thanks, Jane.
Thank you, Jane. And Hugh.
Thank you, Chair. Just like to support the paper and the recommendations, but also to suggest that the board considers further down the track being more assertive in taking action to make sure that we're as inclusive as we can be. And for example, I think that one or two of the points made in the paper is a wake-up call in terms of action, assertive action that is needed by the board and the trust to assure colleagues, as well as to assure the public and the patients that we serve, of our commitment going forward. And in particular, I think today we've heard several times the mention of cultural awareness, and whether it's time perhaps also to consider whether or not the board would want to reflect on the values of an independent cultural advisor, assessor, to monitor some of the work that we're doing in order to ensure that we triangulate the action and be assured that we're moving forward in a most progressive way.
Thank you, Hugh. That's a really good challenge. One of the reasons why I asked Jane about the route for coming back to the board on some of that is because I share your concern that as a board we should give this the priority that it clearly needs and deserves. I'd be really interested from a board perspective to see a proposal around an independent cultural advisor. So Jane, if you want to give that some thought and perhaps come back with a proposal, I think that is that deserves a supportive look, a positive look at that. But hear absolutely what you say, Hugh, and you won't be here to see it, unfortunately. But I hope we will live up to your kind of expectations around that. I'd like to move on, if I may. Philip, you have a question.
Yes, thank you, Chair. Good morning. Philip Jackson, Non-Executive Director, and my apologies for being late for this morning's meeting. It's just a question on the report, Jane, and again on page 5, and just to follow on from what Sharon was asking about the equality impact assessments. And I just noticed with regard to policies, with that there hadn't been any during 2021 equality impact assessments, that is, and yet I do remember, you know, quite a number of policies have been to the board for review and update and approval. I just wondered, do we automatically do another equality impact assessment on policies when we review them, or do we just take the original one as being satisfactory still?
I'd need to ask Peter's help with that particular question, but I think the general point, Philip, is, I think, and it makes the point in the paper, I think that we are at a point where we need to take stock of equality impact assessments and provide more training to people to be able to do them consistently and well. I think for those who are trained and know how to do them, there's the capacity there, but I think it's about rolling out that training, and we do make that point about a training programme for people in the paper. I don't know if Peter wants to add to that.
I can, if that will help. Peter Howard,
yeah,
the Trust
thank you,
Secretary.
Peter.
Yeah, okay. Peter Howard, the Trust Secretary. What has happened over the last year during COVID is most of our policies have had short updates rather than a full policy refresh, and the requirement for the equality impact assessments are when we refresh and do the full quality impacts. So most of what you've seen in the last year have been, as we agreed back in April 2020, have been sort of essential updates, things like changing addresses, details, names. Very few of our policies have been rewritten in that time, and that's when we do the impact assessment. So it doesn't particularly surprise me that there aren't a large number of quality impact assessments, because most of our policies have been updated rather than properly reviewed and revised. I would brace yourself for quite a few coming this year, because a lot of them have been put back a year.
Okay, thank you. That's very helpful. Thank you, Peter and Jane.
Thank you.
Thank you, Philip. I haven't got any more questions or comments. Is there anything else you'd like to say before we complete the item, Jane?
Just on that last point, if I may, Chair,
yeah, of course.
That the review of our people policies and our human resources handbook is a total refresh of those policies. So there will be an equality assessment, impact assessment as part of that. And we, in Sophie Ford, we do have an expert in that. So we will be making sure that that is fully done, given that's a full refresh of those policies. Thank you.
Thank you, Jane. Thank you for a comprehensive report. We've got some clear actions, I think, and proposals coming out of that. It's been a really helpful discussion. So thank you very much. We'll move on to item 3.3, the Speaking Up annual report. And Sarah, I think you're speaking to this.
Thank you, Chair. Hi, I'm Sarah Connery. I'm Acting Chief Executive here at Lincolnshire Partnership Foundation Trust. So the purpose of this paper is to present the annual Freedom to Speak Up report to the board. Just to say, this report has already been through the audit committee, who recommended the board's approval of the report. I'm presenting this paper to you today as the executive lead for Freedom to Speak Up. I'd also just like to thank Philip for acting into the non-executive director champion role, and delighted to welcome Di, who's picking up the mantle on that very important champion role. So I'll assume the paper is read, but I just want to highlight a few things. So at the Trust, we've taken a real pride in making a firm commitment to freedom to speak up since we first engaged our staff on the subject in 2016. And I think freedom to speak up has been really important through the past challenging year where we've faced COVID. So more important now than ever that staff have had that ability to be able to raise concerns. We've implemented service changes very quickly. Staff have been working sometimes in sort of isolated circumstances, and there's been an increased risk of closed cultures, which has been a big focus recently of the Care Quality Commission. So it's our hope that when colleagues do want to raise a concern, that they feel confident and empowered to be able to do so when they don't feel that they're able to speak to their supervisors or managers about any of their concerns. Really important is that this process is seen as learning, not blaming. An important sort of indicator of that, I'm delighted to say, is when questioned, 96% of those who have raised concerns over the year would feel confident to raise them again, which gives hopefully the board assurance that people do feel listened to and concerns are acted on. As with all aspects of work, there's always improvements to be made. In terms of the data analysis, it's getting more, in terms of the comparisons, the statistical analysis, it's getting more detailed, but again, we've got more analysis that we could be doing. We've made refreshes to the Speak Up process itself as a result of that learning, and that's coming on later on in the agenda. Importantly, COVID's eliminated inequalities within healthcare, and we've got a real focus on making sure that all of our staff, particularly those with protected characteristics, feel that they're able to step forward. That said, I believe this report does give the board confidence that we're moving in the right direction to make sure that the trust is as open and transparent as we want it to be, and that staff feel empowered to speak up when they feel that they need to. So I'll leave it there. I recommend for the board's approval of the report, and I'm happy to take any comments and questions.
Thank you, Sarah. For my part, I've been really impressed with the credibility of the speaking up process in the trust, which I think is, robust, has credibility of staff, and the report kind of speaks for itself as far as that's concerned. If we don't have any questions or comments, people are happy to endorse the draft report. No one's saying no, so I assume, yep, the answer is yes. Thank you very much, Sarah. Thanks for presenting that. Let's move on then to section 4 on the agenda, which is risk. And Andy, the minutes of the last 2, I think, audit committee meetings.
Thank you, Chair. Andy Spring, Chair of Audit Committee. The board has in front of it, obviously, the highlight report and minutes of the last 2 meetings of the Audit Committee, as Chairman's already said. There are a number of items that have been to those audit committees that are on the agenda for the board today. There's a few things that I would like to draw the attention of the board to, in addition to those items, if I may. One is the desire of the audit committee to improve. Although we got good results in terms of our assessment, I would want to highlight that we welcome any suggestions and comments from board members and colleagues about how we can improve our work as an audit committee. I would highlight to the board the feedback from our auditors, who find that our organisational responses to their reports are very positive, and that they enjoy working with this organisation, and that they really do see it as a positive working relationships. Huge thanks to Karen and Peter for their administration associated with this committee, which makes it run smoothly. And the last thing I'd really like to draw attention to is the counter fraud work and counter fraud plan. We changed counter fraud service midway through last year. We have seen a shift and change in the way that counter fraud is perceived, and the work of the team associated with that, and that I'd like to highlight that the Counter Fraud Authority changed the standards by which we would be judged at the end of the year in which they were judging those standards. So as a consequence, our assessment, self-assessment against those standards was probably not as good as we'd want it to be, but we have a plan in place to address any shortfalls. I'm happy to take any questions, but I'll leave it there. Thank you, Chair.
Thank you very much, Andy, and thank you for the thoroughness of your reports. Does any colleagues have any questions or comments for Andy? No, I don't. So we note those minutes and the additional information that you provided. So thank you very much for that, Andy. And we'll move on to 4.2, which is yours, Anita, and the risk register.
Yes, thank you. So I'm Anita Lewin, Director of Nursing, AHPs and Quality. So I'm presenting to you the risk register, just some key kind of information. The number of risks held on the organisational risk register are 14. There are an additional 28 risks that are kind of monitored divisionally and kind of go through the local processes there. In terms of our risk register that I'm presenting today, there are 2 new risks. People will notice that they come in a different format when they come as new risks. That's because when we log them as new risks, that there are much more additional information that we need to put in at the point of logging, and it's important that board colleagues have the opportunity to see that when they move on to the full risk register, that they go into a slightly different format. But the 2 new risks are there in detail, and that's around the psychiatrist in North East Lincolnshire that is leaving in October. We've heard earlier from Dr. Dave, the medical director, that we are having issues with medical recruitment. So that is something that the executive team are monitoring very closely and getting week by week updates on that position. And there's additional one around the community mental health transformation and the complexity of the clinical pathways. Sorry, I'm about to. Sorry about that. In terms of additional changes, risk 146 has been reduced. The risk level associated with that has been reduced, so that has now transferred to the divisional risk register. So they're the main changes since the last board. I'm certainly happy to take any questions on any of my risks that are on here, and I'm aware that executive colleagues are allowed to are willing to pick up any kind of comments, questions on any of the risks that they are responsible for. So happy to take any questions.
Thank you, Anita. I've got a couple of questions, but I'm going to exercise Chair's prerogative and go first. First is a comment, and it's just to note the fact that at our next board development session, we're going to spend some time looking at the process behind risk management rather than the individual risks. But I just want to ask a question about the new risk 179, because I don't understand what the risk is. There's a very detailed description of what we have to do, but I don't understand what risk we're identifying there, and as a result I don't understand how we're mitigating it. So if I could have a bit of detail on that, that would be really helpful.
Do you want to come in on that, Ananta? Would you like to answer that? Oh, 179, that's yours, Chris. Ignore me. Sorry, I apologise.
Yeah, I'm happy to come in there. Yeah, so Chris Higgins, Director of Operations, and that was going to be my comment in the what I put in the chat there, is that it's complex risk, and I'm going to go away and have a look at that in terms of being able to articulate that better. I think what we've tried to do is capture the various elements that are concerns within the community transformation that collectively cause concern, to be able to put it on the risk register. But I think I just need to give it some more thought about whether we separate those out into different separate risks, which might be better, but certainly articulating that in different ways. So yeah, definitely note it, and it just needs a bit more work, and I'll bring that back to the next iteration, if that's okay.
Yeah, no, that's fine, Chris. I don't think we've actually crystallised a risk out of that, have we? We've just described a difficult set of circumstances.
Indeed, no, yeah, point taken, and I will make sure it's better for next time.
Thanks very much. Tim.
Thanks, Chair. It's a quick question, some detail. Thanks very much for the report. On the risk 146, which is now at a divisional level, and the risk rating has gone down from 16 and extreme to a level that it falls on a divisional risk register. I just wondered if, very briefly, what has actually changed to cause that decrease in risk?
Do you want to come back in on that one, Chris?
Sorry, I was rapidly shuffling my papers. Chris Higgins, Director of Operations. So yes, the reason the risk reduced is that we've got, whilst we're still operating across two systems, there's Mosaic, which is a council local authority operated system, and there's the Rio, the LPFT system, is we've got new processes in place to be able to manage the transfer of information and sharing information. So local authority colleagues now have access to honorary contracts, so they can access to Rio, so they can see relevant information and vice versa. So whilst it's not an ideal situation in terms of a shared system, we've got processes in place that allow us to share relevant risk information so that patients aren't in any risk. So whilst it'll stay on the risk register at divisional level because we want a longer term solution, the appropriate mitigation in place to be able to manage it at a lower level.
Lovely, thanks, Chris. Can I just make one quick comment, Chair? It might be helpful if, because it's moved to a divisional risk register, of course, it's not on the ORR. So I wondered if any lines of risk which are subsequently transferred stay on there for one meeting with an explanation of why they're going to be moved off.
Can we pick that up at the board development session in August, where we'll talk around the architecture around risk management, and that might be something worth feeding in then, Tim, if that's okay.
Yeah, no, that's fine. Thank you.
Thank you. Hugh.
Thank you, Chair. Relating to the risk that you just discussed earlier in terms of community, just a note of caution. I think it's right that we should pursue pathways that involve community groups. Maybe what is needed is a little bit more due diligence in our approach to ensure that we've got in place strategic partners to work with to minimise any issues in terms of risk. So that's maybe just a cautious note in going forward. I think it's still important to have that pathway. The question was also about what action are we taking now, knowing that we're going to need a new consultant for young people, children and young people, bearing in mind, again, pressures building up at the back end of the summer, going into the autumn term, and the support that young people will need. What are we doing now?
Anant, do you want to come in and pick that up?
Yes, thank you, Hugh. It's a good question. So what we are doing now is we have a program in place to develop our specialty and associate specialist doctors to act up to consultant positions. So the developmental associate specialist program that I mentioned earlier, which allows these doctors to step up and be supported. So we have 2 candidates within the specialist division whom we are preparing to take up those positions if we are not able to recruit substantively over the next 2 months. Even if we do recruit, depending on who is recruited, there will be a notice period, etc. So we do have this DAS position in place. Our least preferred option is going through an agency locum because it will impact on continuity of care. However, that is also an option that we will use if we are not able to either recruit substantively in time, or if we are not able to get developmental associate specialists to cover for the whole. It's a full-time post, so we might have to have some blended options, but we are in conversations with the SAS doctors as well as working closely with the current incumbent. What we've also done is worked very closely with the non-medical prescribers. So the consultant has trained 2 non-medical prescribers in the team to pick up urgent prescribing issues so that there is some continuity around that element of the service. Even if there is a delay in appointing to a substantive consultant. So that's what's happening currently. Thank you.
Thank you, Ananta. I think that's very helpful. And there's a question from Andy.
Thanks, Chair. Hugh's partly stolen my thunder because it was going to be about the same risk 177. My question was going to be, what are the additional mitigations we've got in place? And I think Ananta's highlighted those. So rather than a question, it's a comment. We ought to add those mitigations as additions to the risk register to identify that we have other plans in place other than just the recruitment.
Thank you, Edward.
Yeah, I think that's a good point, Andy, and one I was going to make in my summing up. So, any further questions either for Anita or for other colleagues on the detail of the risk register? If not, we'll revisit the process around risk management at the next board development session. Chris, you'll come back or reflect on the way that we've framed risk 179, and let's pick up Andy's point about making sure that we've got a comprehensive description of risk mitigation when we're coming forward with new risks in this way. But other than that, thank you very much, Anita. Thanks for the report, and thank you, colleagues, for expanding on elements of the detailed risk register. So let's move on then. Anita, I think the floor is still yours for item 4.3.
It is. Thank you very much. And apologies to colleagues for the late entry this made onto the board papers today, but it's important that I get this discussed at board and taken through. So this paper relates to what is now quite commonly known as Pingate, and the exception that was given by Public Health England and the government last week around NHS staff and potentially being pinged by the NHS app and being able in exceptional circumstances to return to work. I have gone through this in detail with kind of colleagues in the executive team and operational managers, and indeed have linked in with our local public health department and colleagues in the system. I think it's fair to say the key part of this guidance is around exceptional circumstances. This isn't something that we would routinely plan to implement, and it certainly isn't part of our kind of standard business continuity going forward. We would use our other business continuity contingencies prior to kind of implementing this. But I didn't want to be in a position where we were considering implementing it without board having had sight. I have included the detail of the flowchart that we've devised that will be used, and there are some really key areas. So I think the first bit is, if we are considering returning a staff member to work, the first point is, actually, to be fair, in a situation that two of us on the call have been in the last week, we couldn't, if it related to a family member living in the same house. It is people that have been potentially out socially and then kind of get pinged, but there are a lot of rules around this. We obviously have to have a negative PCR test. They have to have daily lateral flows. They have to work in areas where there aren't high risk patients. So we know potentially our high risk areas would be our inpatient units in terms of staffing, but then we know those inpatients are often in the clinically extremely vulnerable by the sheer nature that they have a serious mental illness, potentially coexisting with a learning disability, which puts them in the high risk areas. So in terms of making final decisions about returning staff to work, I'm very clear this should not sit at kind of service manager, ward manager level. These are high level decisions that need to be made, and therefore have added into the flowchart that any decisions will be signed off either by myself as the director lead for infection prevention and control, or by the Gold on Call. We've spoken about this a lot, and to be fair, as an organisation, our staffing levels, have been affected by Pingate. There is no doubt about it, but we have worked hard, as we always do, to support those services to kind of manage through. There isn't a feeling that this will become something that we will need to kind of resort to but I wouldn't want to be in a position where this really is our final resort, where patient safety is affected if we don't implement this and board colleagues haven't been cited. I think just a last final point that I want to make before I kind of pass over to colleagues is, and we are all aware there are updates to this, what feels like hourly. So this potentially could change at any time, and I will obviously keep people up to date and in the loop. I mean, while I've been on this board meeting, you know, just shy of 700,000 people were pinged last week, and again it's come through and said, you know, the government are looking at it again. So any further updates that come through, I will make sure board colleagues are kind of cited on it, but it really is to ask board colleagues to approve the process should we have to implement it. But I don't foresee that happening anytime soon. We have business continuity to kind of go to first. So that's it, thank you. And I am happy to take any questions about this one.
Thank you, Anita. I think there are two questions here, aren't there, that you want the board to answer. The first is, are we content to have this exceptional process as a last resort to be used, you know, when circumstances require it? And then the second question is, if the answer to that is yes, are we content that the process that you've described in your paper is suitably robust and rigorous? So can I ask those two questions separately? First of all, are colleagues content that this exemption should be available to us and we should use it when necessary? And then secondly, can you indicate whether or not you're content that the process that Anita is proposing is sufficiently robust? One yes to answer both questions. Mark, thank you very much for giving me two whys. Yep, so the answer, there's an overwhelming response, Anita, both that yes, this should be a tool available to you, and yes, the process that you're proposing is suitably robust. So you can take it that the board's agreed on both counts. Thank you. And thank you, I should say too, Anita, for presenting that so clearly, and as the other person on this meeting that has been isolating and all the rest of it for the last couple of weeks, I can confirm that the guidance is never quite as clear as you'd like it to be. So being able to navigate your way through this is some achievement. So thanks very much.
Tim has a comment, Chair.
Well spotted. Sorry, I can't look in two directions at once. Tim.
Thank you. Yeah, I mean, obviously fully support it, as I stated. Quick question, I'm absolutely sure the answer is yes. So there is a process for monitoring the level of pinged staff across by division, etc. Yeah, thank you.
Absolutely, and we have a daily position that goes out to the executive team and everybody in the organisation. So yes.
Yeah, thank you. I knew that would be the answer, but thank you.
Thanks, Tim. Thank you, Anita. Let's move on then to section 5 in the agenda and item 5.1, Sarah, which is your Chief Executive's report.
Thank you, Chair. Sarah Connery, Acting Chief Executive here at the Trust. I'll start my report as I usually do with COVID-19 update, but won't repeat what Anita's just updated the board on in terms of increasing staff isolations as a result of Pingate, as well as actually increasing infection levels as well. So we have had a number of outbreaks across the Trust in July, Asheville Award 12, and more recently the Boston Crisis Team. And I just want to reiterate what Sharon Robson said earlier around the IPC leadership at the Trust is really strong. A massive thank you to our IPC leaders, as well as all the staff, for managing those outbreaks really well and making sure that they were contained. Just moving on, I think it's worth pointing out that our sort of key message for staff is continue with infection prevention control despite the opening up across the rest of the country. It's quite a difficult message to manage with service users and visitors as well, but in healthcare settings we need to remain vigilant and reduce our risk of infection as much as possible. In terms of the COVID vaccination programme, Lincolnshire, as I've reported previously, has been very successful in working in partnership together to get really good results. And now our focus is turning to future vaccination programmes that will be delivered later in the year, not just for COVID vaccination, but also for flu programme, which will be really important this winter, as it usually is. In terms of regulation, we've had 3 inspections from Care Quality Commission to Mental Health Act inspections. These were carried out virtually on the Wolds, the Fens and the Francis Willis unit. We've had our reports back around the Wolds and the Fens, and I'm delighted to say, following the interviews with staff, patients and carers, that they were extremely positive. As with any inspection, there are some actions for us to address, but the CQC were very impressed with caring, knowledgeable staff that they interviewed throughout the day, and also high levels of patient satisfaction. So a massive thank you to those wards that were involved in that. Big focus, as I mentioned in the Freedom to Speak Up report, is on closed cultures, and the Trust is doing a lot of work promoting assessments or self-assessments within areas across the organisation and offering support to do that. In terms of what's happening nationally, it will not have passed your attention that the Health and Care Bill is now finally going through Parliament, and it's had its 2nd reading, so is now being put forward for royal assent. We did have some NHSEI guidance around what that would mean for the NHS, but as the legislation has been tweaked through the process, it'll be coming back to the board at a later month once it's settled and finally agreed. But we've included a link there to an on-the-day briefing, which is really helpful from NHS providers in terms of summarising that position. Regardless of the Health and Care Bill, we continue as an organisation to work and play really heavily into the system, not just in Lincolnshire, but also to the East Midlands Alliance as well for mental health, learning disabilities and autism. We've had a joint working executive time out with local authority colleagues, with public health, with district councils, in terms of what our priorities are going to be through this year, beyond COVID, into the future, in terms of what we need to do as a system together to really push the dial around reducing health inequalities and improving population health in Lincolnshire. In terms of our work with the East Midlands Alliance, we've had 2 board development sessions this month, and I hope board members enjoyed that time. These were the first sessions that we've had in terms of all of those organisations, all 6 of those organisation boards coming together to talk about governance, patient outcomes, and how we're going to measure success versus the capacity required to input to those developments. In terms of Lincolnshire, the Mental Health, Learning Disabilities and Autism Partnership Group continues to meet monthly. I'm delighted to say it's got really strong engagement from system partners. We've now got representatives from district councils, as well as the Shine network as well. And the next meeting will be signing off our system objectives for the second 6 months of 21-22, sorry, as well as the longer term strategic vision and priorities. A little update around some of the key pieces of work around LPFT. I won't mention the eradication of dormitory project, we've covered that previously, but just to say that the community mental health transformation is really starting to motor on in terms of the rollout, particularly around the integrated place-based teams. So we're linking very closely with voluntary, community and social enterprise sector, massive great emphasis on building community assets so that more people can be supported to live well in their communities in line with our strategic vision. Just to say that we'll be covering this in a lot more detail as we progress with our successes, and a board development session will have some focus on this in December. It'd be remiss of me not to mention that we've got Council of Governor elections, so we're holding elections this summer for 8 of our public governor seats, and we're trying to promote that across our social media channels to make sure that we've got people putting themselves forward. Our governors obviously play a vital role in working with our board to help shape trust direction and represent the views and opinions of staff, service users, carers and public members as well. There are also by-elections for 3 service user and 1 staff seat, and voting will take place through August and early September. I just want to finish off with some celebrating success information. Our Francis Willis Unit patients have been named in a number of national awards as finalists, so really great service user engagement there and empowerment. So finalists have been invited to a celebration evening on the 21st of September. Some of the projects shortlisted include street wall art, smartphone movie making projects, and also monthly health challenges in breaking down barriers. So if you are at the Francis Willis Unit, please do go and have a look at some of the great work that the patients and the team there have been working on. Finally, just want to say, as I often do, a massive thank you to all of our staff who continue to work through really challenging time, particularly as we're coming up to the annual leave period through the summer. We're making sure that staff are able to take their annual leave, much needed respite, to make sure that we're sort of fit for what we're facing into the winter. But I just want to end with a massive acknowledgement and thank you personally from myself for all that they do each and every day. And I'm happy to take any comments or questions on the paper. Thank you.
Thank you, Sarah. Two things from me. The first is I want to associate myself with your thanks to staff. And the second is an opportunity to exercise my inner pedant. The Health and Care Bill is not about to go for royal assent. There are several stages in the House of Commons and the House of Lords before it gets anywhere near there.
Noted. Thank you.
Peter, I think, has an update on governor elections, which I think it would be helpful to hear.
Great, thank you.
Yeah. Okay, it's Peter Howie, Trust Secretary. So just to let everybody know that actually during the meeting that's been going on, I've just had an update on the nominations and candidates, and subject to the fact they can still withdraw up until tomorrow evening, every single seat has at least 1 candidate, so it's likely we will fill every vacant seat.
Thank you for that, Peter. That's good news. Are there any questions or comments for Sarah? I'm going to allow myself one more, Sarah, and that is your report just demonstrates that, putting it slightly flippantly, that there's a lot going on at the moment, and I absolutely recognise the demands on you and the rest of the exec team, and look to you to make sure that you are clear with non-exec colleagues about the limits of your capacity, and that you're properly supported in managing the kind of complexity that we're going through at the moment. I do have one question from Tim.
Sorry, it's a question and a comment. If I can do the comment first, just on the acknowledgement of staff that you quite correctly raise, and my comment would be, having done a site tour with you, Sarah, and met some of the staff, that the reality of that really came home to me. So they do a fantastic job. My question really was around, you raised the Alliance Board Development Days, and one of the subjects that came up there was around obviously the commonality of challenges around recruitment of staff, and there was comment which I think is perfectly valid, but I'm not quite sure how it is going to go. So really, it's, if you'd like to comment on it, about how we work as an alliance together, so we don't have unintended consequences of maybe something we do in a trust from a recruitment basis, and how you think that might work.
Thank you. Yeah, really good question, and particularly around medical recruitment, where we have to be quite careful about what we're doing around recruitment and retention premia, and just sort of losing staff and then moving around the alliance. So we do have those conversations as a group of chief executives, and we've made that pledge to, if a member of staff does want to move on for whatever reason, then it's facilitated from both sides. But in terms of the specifics around the workforce challenges, we've agreed that we need a bit of a capabilities framework, maybe, that we could work on as a alliance. because there aren't enough qualified nurses to go around if we were all to fill our vacancies. So we need to think more innovatively about new roles and work as an alliance on what that might look like. So that is being taken forward as a dedicated session for the people directors from across each of those 6 organisations. So great question. Hopefully that's answered it. Thank you.
No, that has. Thank you, Sarah.
Thanks, Tim. I'll just add to that. Some of us have taken part in Alliance board development sessions. There was one yesterday and there was one last week, Sarah, that you were involved in. And one of the things that we reflected on in yesterday's session is that as well as thinking about how we structure that alliance, we ought also to recognise the fact that it provides us with real opportunities around, pooling of capability, whether that's people capability or other capability, and we perhaps ought to spend a bit more time on realising the potential of that than thinking about the kind of intricacies of governance, which is taking up more time at the moment than it probably ought to.
Absolutely.
Sarah, thank you very much, and thank you for a comprehensive and helpful report. Oops, muted myself then. Let's move on, if we may, to item 5.2, Chris, which I think is yours.
Yeah, thank you, Chair. So Chris Higgins, Director of Operations. So pleased to be able to present this report today. It's a culmination of quite a lot of inputs from a number of different groups and events and key leads within the organisation to pull together what are the high level actions and activities that we'll take over the next 3 quarters this year to lead us to a position of new normal following COVID-19, and described as a roadmap to recovery for the organisation. And the idea is really to set those out so that staff and other stakeholders can see what we're going to be involved in, how they can play their part, and they know what's coming and know what to expect in terms of changes over the next few months. When we started the piece of work, we put developed really quite a long list of activities, but what we've tried to do is distill that down to only those things that are specific to COVID. So obviously within the organisation, there's lots of different departments working on lots of different things over the next few months that are kind of business as usual activities. This is really drawing out those things that are really particular to COVID, will make a difference as we lead to that new normal. What we'd say is once we've got to an approval stage, we'll share that with staff and other stakeholders. Obviously, because of the nature of the pandemic, it is subject to change. This is based on the current roadmap and the expectation that as we progress through the next few months, restrictions will ease, herd immunity will take effect, and we'll start to progress out the other side of COVID, but recognising there's going to be some elements of COVID that we're living with for some time to come. The recommendation is that if approved today, that it's then overseen by the Sustainability Committee in the Trust, so we can track progress and make sure things are moving in the right direction and update the board accordingly from there. So I'll stop there and invite any comments.
Thanks, Chris. That's really clear. So the question is that the board should approve the roadmap as proposed. Has anyone got any questions or comments for Chris? Andy?
Thanks, Chair. Chris, I note going through this that in effect only on Q1 are there elements linked to finance and digital, and they're predominantly ones that link in with this year. Is there? You mentioned that basically these are the things that are only linked to COVID and recovery from COVID. But I just wonder if it's worthwhile incorporating something that links through to 22-23 and our future plans in the further quarters for those, certainly for those 2 elements, because we know that digital is going to become part of our normal way of working, and we also know that financially Lincolnshire is a challenged system.
Yeah, good point. I think where we'd set this up is that really the bulk of the activities you can see from the paper is all going to happen over these up to September, really, because if everything goes according to plan, we'll be progressing to a new situation from September, well, from October onwards, where we're delivering those things about that blended approach to delivery, and we're really adapting his ways of working. So this should tail off as the year progresses, but certainly take the point in terms of that, and welcome views from the board on whether we build in some other elements that demonstrate that continuation of practice beyond 21-22 or not really. It's difficult to know where to draw the line on this one, if you don't mean. I don't know what the other colleagues think.
I think probably the priority here is getting something out relatively quickly, and if necessary, then adjusting that over time. As you said earlier, Chris, some of this is a movable feast, isn't it? A lot of these parts are going to change over time, so I think I'd be in favour of publishing this sooner rather than later, and then if necessary adding to it over time. There's comment from Tim.
Yeah, just really sort of wearing, I guess, my ex-PHE hat and sort of COVID, just to say I think, having seen the detail as well behind it, it's a really good piece of work, and that's really all I wanted to say. Thank you.
Thanks, Tim. Sorry, technology momentarily defeated me. Mark.
Thanks, Chair. So, morning everyone. I'm Mark Platts, on the Acting Director of Finance and Information for the Trust. So just picking up on Andy's comment really. So the focus of this is around the COVID area, and I think for a lot of the financial restore section for getting us back to our normal contracting methodologies, really, that kind of falls within the July to September. So we're anticipating the guidance for the second half year of the financial plan for this year to be released in September. So I think nationally everything's quite condensed this year, and we're splitting the year up into two, which is an unusual one. But certainly following that, it's been quite clear nationally that from April we're going to be under the kind of pre-COVID contracting regime. So a bit of a normal position from that really. So we haven't included anything from the COVID restore, but picking up on Andy's point, extending it into future years, we'll be bringing in the planning in at that point. Just wanted to have that context around the finance element. Thank you.
Thanks, Mark. And Philip.
Yes, thanks. Philip Jackson, non-exec director. I just wanted to agree with you, Chair, about getting this sort of up and running and implemented as quickly as possible. And I note the recommendation to keep it under review by the Sustainability Committee. So as Chair of that committee, I'm perfectly happy to take that on and ensure that we feed back to the board on a regular basis as to how it's progressing.
Grateful, thank you, Philip. And Jane.
Thank you, Chair. Jane Marshall, Director of Strategy and People. I really welcome this too, Chris. I think it's a great piece of work. The context for this as well, in terms of our partnership with the Lincolnshire Local Resilience Forum, is really important, that we're demonstrating through this recovery map progress that aligns with their expectations of what we should be doing as they go about their work. So really welcome it, and I think it's important to ensure we note that context. Thank you, Chair.
Thanks, Jane. Chris, I think you've got a couple more comments before I conclude this.
Yeah, just to say, picking up on the comments of Andy and others, and also the recognition we need to get something out. I think that if my proposal would be to put this through the Sustainability Committee, and then in the committee's meeting in November, we can do a bit of a stock take on where we're at, and then maybe do a refresh of this at that stage, depending on where we are with COVID, if that would work.
Yeah, that sounds sensible, Chris. And my conclusion on this was going to be, as I said before, the imperative is to get something out and in the public domain. We've got a process for monitoring delivery and agreeing changes to it if we need to through Sustainability Committee, but it's more important that we get something out sooner rather than later. And just to echo what others have said, it's a really first-class piece of work, really clear, and with some comprehensive consideration that's gone on behind it. So thank you very much. Thanks, Chris. I should have said, and I can't remember whether I did or not, but I should have said at the beginning of the meeting that there's a change to the published agenda in that item 5.3, which would have been considering next the review of the trust strategy, decided before the meeting to remit that back to the relevant committees and then take it in the future back to the board when it's been through those committees. So we won't be taking that item today, which takes us on to item 5.4. Ananta, it's back with you, suicide prevention strategy.
Thank you, Chair, and Ananta Dave, Medical Director at LPFT. I'll take the paper on the suicide prevention strategy as read. It essentially aims to demonstrate the various streams of the strategy, which encompass training, development of capacity, and required process for investigating of incidents, care planning, working with bereaved families and carers, and looking at the capacity and planning within each division of the trust, the operational divisions, to progress the work. So I'm also pleased to report that after a period of pausing some of the developmental activity due to COVID, all the divisional plans have been reviewed. They are on track, and we are making good progress with our training and with the various steps being taken to improve in capacity around investigating serious incidents due to suicide, and also learning from them. So very happy to take questions or comments about the details in the paper. Thank you.
Thank you, Ananta. It's a very, very detailed and comprehensive paper for which I'm really grateful. Are there any questions or comments from colleagues? No, well, the recommendation is that the board receives the report, which is and the assurance that it provides. I think it provides a high level of assurance, and I think we can receive it with agreement. Thank you very much, Ananta. Let's move on then to section 6 in the agenda, operational performance, and item 6.1, Philip, which is the Sustainability Committee meetings. Minutes, I should say.
Yes, thanks, Chair. We've got the draft minutes of the Sustainability Committee of the 13th of May and the highlights report. I'll take it as read, but just make 1 or 2 points. There are a couple of business cases in the highlight report, which of course are now historic because we considered them at an earlier board meeting. So I guess we don't need to worry about those too much at this meeting. We also at our meeting in May, we were also concerned about the continued fragility of the Lincolnshire system finances. And I guess that's something that's going to continue to feature on our agenda, both as a trust and as an area as time goes forward. So those were probably the 2 main points I just wanted to bring to the attention of the board, Chair. Thank you. Happy to take any questions or comments.
Thank you, Philip. Any questions or comments? As you say, I'll give people time to type. As you say, the 2 business cases referred to kind of took a circuitous route, but the board has already signed them off once. I don't think there are any questions or comments. So thank you, Philip, for a helpful and comprehensive report. I'm grateful. Thank you very much. And let's move on then to Mark, the integrated performance report.
Excellent, thank you very much, Chair. So good morning, everyone. I'm Mark Platts, I'm the Acting Director of Finance and Information for the Trust. I will present the integrated performance report as read, and just to say that we'll note any actions that might arise from any of the discussions during the paper as well, so I'll make sure we pick those up. Before I go into the exceptions around our national oversight and performance metrics, I just wanted to give the board and public really a bit of context of where we're going in terms of developing our integrated performance report. So there's been a lot of national and system focused around the development of reporting metrics, and the NHS system oversight framework has been quite clear in terms of the direction of travel of how organisations should be monitoring our performance. So our business intelligence team are working hard to pull together all of these requirements, start to look at options, and we do have a board development session at the end of this month where we'll be presenting some slightly revised tweaks to the format of the report to make sure that we can increase our accuracy and reflection of our reports. So again, I think I've asked this previously, but if there are any members of the public that do have any views on the way we present our data, please let us know through the contact us section of our website, and I'll quite happily pick those up as part of the board development discussions. So the report will look quite different moving forward, but hopefully we'll start to reflect more meaningful data as we continue to develop it. In terms of the oversight and trust performance metrics, which start on page 6 of the report, I'm just going to pick up a couple of key ones on these. Again, the key metrics that we have discussed over a number of months. So they focus around the physical healthcare checks, so both around our inpatient services and our early intervention psychosis patients. So there's a lot of work gone into this. And I know previously over earlier months we've been talking about remedial actions and plans that we've got in place to make sure we can kind of improve performance on these. A bit of good news really. So whilst we're not necessarily meeting targets across both of them, performance is really increasing and ramping up. So we're now exceeding our target around the inpatient area, and then for the early intervention and psychosis one, which is metric 11, we've actually increased from 75% last month to just over 86 this month. So it's a really positive developments from the team on that. So really good move on that. And also linking to Ananta's great update on the medical director earlier on, there's a lot of work across the medical division to help develop and improve the performance against metric 29, which is our actual consultant-led referral to treatment metric. So we are now firmly on plan and evidencing a really positive trajectory around delivery on that one. So we're looking good to meet our September target on that one. So happy to take any questions on the oversight and trust performance metrics before I hand over to Chris for the divisional updates. Thank you very much.
Questions or comments for Mark? And if we can we keep questions and their responses as crisp as we can, because I'm really conscious of the clock. We've still got some ground to cover and a private session afterwards, and it would be nice if we could do that without people falling over through lack of sustenance. So Sharon, I think you have a comment.
Yes, thank you. I'm not sure, Mark, it's your bit or the next bit, but it relates to the operation metrics. And it's around the eating disorder waiting times. I visited the service recently with Anita, Director of Nursing, Allied Health Profession and Quality. And the narrative around this says that it's about the psychologist post, and whilst that's a big part of it, I think it is a whole pathway issue with this service, which I felt needed reflecting within the performance report. It's not just about the psychology service, it's about the location and the facilities, so it's a whole pathway issue. So I just really wanted to bring that up.
Thanks, Sharon. Is there a comment on that before we move on?
I can comment on that, Chair, if that's all right.
Chris, and is your section next anyway? So
it is, yes. That's all.
Okay.
That's what I'll feed on into.
I'll leave it with you. Yeah.
Yeah, no problem. Just on that specifically, for Sharon, sorry, Chris Higgins, Director of Operations. The piece that's covered in here predominantly relates to children and young people's eating disorders in the report. So the adult element is not covered in here, but you're quite right, Sharon, is that we've got a number of challenges around the adult eating disorder pathway. That service is subject to is part of the community mental health transformation programme. So there's a lot of work to do around the transformation of that particular service line and investments to follow. So it's not where we need it to be, and it's under pressure because of increasing demand. But there's a plan in place to be able to bring that together and hopefully to get the capacity to match the demand that's coming through the door. So. But if you have any further questions around that or any comments afterwards, then please give me a shout and I'll have to pick them up. So what I'll do is I'll canter through the divisional updates and then pause for questions at the end, if that's okay. So I'll just start with the adult the adult inpatient division, which starts on page 12 and the narrative on page 14. Just to highlight a couple of things. One is the 30-day readmission target, unplanned admission target, is something that sits in the adult inpatient division, and there's a programme of work that we've got underway to improve that performance. But just to say that a lot of the actions that will lead to reduction in that readmission rate actually sit within the adult community division, and so I'm working with the adult community associate director to improve their or increase their input and ownership of that particular target, and we'll reflect that in future reports. Just I think a couple of things to highlight really is that the community rehab service is expanding out, now taking referrals county-wide as part of the community mental health transformation. That's excellent and a step in the right direction. And also just to say, because it's been raised elsewhere in the report, is around ECT, electroconvulsive therapy, which is a specific treatment that we provide in mental health services. Is our unit at the PHC department at Lincoln has been given ECTAS accreditation, which is Royal College accreditation, because of the work and accommodation that followed with that. So really good to see that. From a performance perspective, there's an issue in terms of falls in adult services, unusual for adult services. Often that's more associated with older people services. It particularly related to one patient who had some issues around their mental health and some thought disorders that affected their eating and nutrition. A robust care plan's in place, and that is now being managed effectively. Just a flag, I will say, for the adult inpatient division is the increased short-term sickness. We all know the impacts of COVID, and I think we've relayed them through here, but staff are tired after a year or so going through that, and that is impacting on staff's sickness, and obviously compounded by the number of people having to isolate because of being pinged by the NHS app. So challenging situation, but manageable at this moment in time. I'll move to the adult community division, which is starting on page 17 and the narrative on 19. Just to flag a couple of points there is similar to the rehab service, community rehab service, we've got the PAC service, which is the personality and complex trauma service, is now rolling out as part of that community mental health transformation. And referring to my previous point, is they've got a key role to play in avoided admissions and those return admissions into the inpatient wards. That 30-day readmission target predominantly relates to people who've got personality and complex trauma, and so this team is now reaching into the wards to be able to help with that, and so hopefully we'll see an impact in the future. And also on there, which Ananta may contribute to if there's further questions on that, is the referral to treatment, RTT performance. We know we've had an issue because of medical availability, particularly in Lincoln area. An action plan has been put in place and the executive team has signed that off, and we've got a programme of extra work that's been in to bring that back on track, hopefully by November. So over to the older people and frailty division, just to flag a couple of areas of interest and good practices. We're really trying to increase the psychological provision for our older people in the trust, both on a dementia perspective and those on the complex mental health pathway, by introducing some new roles, and they're currently out to advert. I've also building on the work that Dr. Adaves started in terms of the dual diagnosis work. We've now got 2 workers, one started in Lincoln, now another one in Boston, who are We Are With You, the addiction services, and they're working as part of our teams for the mental health liaison services at the hospitals in both Lincoln and Boston, and really having a positive impact for that patient group, so that's excellent to see. And then also just to flag, if you haven't seen it already, there's the Langwood Ward video clip, These Hands, there's a link in the papers. If you haven't had a look at that, it's definitely worth a look. Then finally, moving over to specialist services, just to flag a couple of areas of concern. This is where the adult eating disorder services sits that I referred to earlier. One is the CAMS weights. So routine CAMS weights, children should be seen within a period of 6 weeks. We're now operating an average about 7 weeks because of pressures, particularly around Boston. That CAMS weight or routine weights incorporates a number of services or service lines within it. So there's a core CAMS service, there's an eating disorder element for children, and there's a learning disabilities element for children. So 35 children have missed that 6-week wait in total, 29 of which are related to one particular team in core CAMS, and we've got a plan in place for that to be back on track by September following some successful recruitment. Within that is this smaller number of children, 6 children, who missed the target for really eating disorders staff within that team, and that is a particular issue here in terms of capacity to meet that demand. And so that is an ongoing problem we're just keeping an eye on, but we're going to have to get some additional investment in and recruitment in to be able to bring that back on track, and that's still work in progress at the moment. So I have asked, just so the board's aware, is because of the complexities of the way that we report and record and report on CAMHS weights, that I've asked for a deep dive to be done, so that'll be reported through to the Sustainability Committee for November, so we can really understand the range of weights that are happening in CAMHS and get a better understanding of that, and that'll influence what we report through this IPR in future. And the other one to flag on here really is the concerns we've got around our autism weights. The Service Commission for 200 assessments per year, and we're seeing that rates coming in at about 500 over the last year, significantly outstripping the demand, the capacity we've got available. That's been compounded by COVID and our restrictions on being able to deliver things over the last few 18 months. We're working with commissioners. We can't resolve that waiting time target on our own and reduce the backlog on our own. We need additional investment into the service, and so a business case is being produced and will go through to the new Contracts Partnership Board for consideration. So it's just to say, unfortunately, this time we're not able to put a time frame on when that performance will be back on track, because it is dependent on investment locally. So I'll report back on that in future months. So I'll stop there and take any questions.
Thank you, Chris. A comment from Andy.
Thank you, Chair. What I was going to say really was, we look as though we've got a number of challenges around access targets across the board, but we have a sustainability committee in a couple of weeks' time, which I think we'll probably need to cover those for the board in general. But my broad comment is there are a number of real positives in here, and we tend to focus on the negatives. There are a number of areas where we've continued to deliver, good performance, and I think we should say well done to the teams for doing that. And it's good to hear that the detail to which Chris is able to go on some of the areas where we've got challenges, to know that there are action plans in place.
Thanks, Andy. Hugh.
Thanks, Chair. Thanks, Chris. In terms of the specialist services, the children and young people services in particular, just to say that, we've always thought that we knew that there would be latent demand. This is now coupled with challenges in terms of vacancies as well. So can we be assured that we'll do as much as we can to actually expedite strategies to help young people in the interim if we haven't got a full solution?
Yeah, just to come back on that, of course, Hugh. Definitely, the team are working closely on that, and just a bit of context on there is there's also a working partnership with our local authority, with the lead commissioner for children's services in Lincolnshire, to review a kind of system review of those of children and young people services. We know that some of the new access targets that are coming out are going to be challenging for us as a system, but it's an opportunity to try to look at that and provide a more responsive service. So certainly over the rest of this year, we're working to a position of bringing that down to a 4-week wait maximum. So as you know, we're operating at 6, and it's really bringing that down. So that'll be a challenge that'll for us all, but it's the right ambition. But quite right, in the meantime, being able to offer service users and their families some support while they're waiting is exactly what the team are trying to do.
Thanks, Chris. A couple of comments from me, if I may. The first is I'm looking forward to board development session, so we can take stock of how we present performance, and whether or not we can improve the quality of the insight that we provide through the way in which we present the information. That's going to be a good conversation, I think. I personally take significant assurance from the fact that in presenting this, you're demonstrating a significant level of for grip, for want of a better word, on the issues, and the assurance provided by the clear link through from areas where we're not performing as well as we would like to the action plan, and that clarity of insight and link it offers really significant assurance, and I appreciate that, and I appreciate the care and attention to detail that's gone into presenting this report. So thank you very much. If there are no further questions or comments, we will move on to item 7.1, Peter, which I think is yours.
Kevin, I'm happy to do that. Can you just check there aren't any finance or people issues in the IPR report?
Oh, sorry, if I moved on too quickly, I apologise.
You may not have done. It's just I know ordinarily Mark would say something about finance.
Yeah, apologies, Joe. I was just going to say, if Jane wants to come in for the people section, then I've got a really quick update on the finance section.
I do apologise. I was getting carried away with myself.
It's not a problem at all, Chair, and I'm sorry to bring you back to it. I just think it's important that, given the risk on the people agenda that this report shows us, we come back to some of the task and the actions that we.
Yeah, of course. What threw me was the fact that Mark had referred to that in his introduction to the report, yes, and I didn't know that you were going to add to it, so I do apologise.
No, that's no problem at all. I just think it's important, given the level of risk that we know we're carrying, and when you look at the triangulation of the data in here, you've got increased short-term sickness covered by safe staffing information, which Anita and colleagues, Anita Lewin, our Director of Nursing, AHPs and Quality, has provided, and also the impact on agency costs. So the rapid recruitment team's work, detailed on page 31, the task has been really to take rapid action to address the 40 qualified nurse vacancies we have in 4 of our highest risk wards, which are our acute inpatient wards. And you'll see from the detail on page 31 that through the work of the execs, and I completely appreciate their support of me in this piece of work, we've made good progress so far. So of those 40 vacancies for qualified nursing posts, we know at any one time through normal routes the pipeline will only supply up to 20 people to fill those vacancies. So we have agreement to go through international recruitment, an international recruitment drive, which is referenced on page 31. To work with a partner organisation, specialist recruiter of mental health nurses, to bring up to an additional 20 nurses into our trust. That work is progressing well, and we will be taking a paper to the Sustainability Committee to give assurance on the processes we've followed for that work, but just to say to the board, to give assurance that we are absolutely working hard to make sure that we get those people in. The next task we have is retention. So the focus of the rapid recruitment team will start to focus more on retention, because of course we've got a 10% overall retention or turnover rate, but we know within that there is variability within some of our service areas. So we'll be bringing forward further updates on that as we go through. Thank you, Chair.
Thank you, Jane. I appreciate that. Mark.
Excellent, thanks, Chair. So if I can just close by just giving a really quick update on the sustainability finance section, really. So the Trust continues to report as required against a half-year 1 position. So this takes us to the end of September. So we are currently meeting our break-even target as a system and as an organisation, and we're forecasting to meet that by the end of the year as well. But just to bring to the board's and public's attention, really, obviously, as we move into the second half of the year, nationally, we've still not had confirmed our positions that we're required to meet in terms of targets for our Lincolnshire system or for our organisation. So we are working on a very clear directive of travel that there will be an increased ask for additional savings as we start to, as a country, come out of recovering from the financial implications of dealing with the COVID-19 pandemic. So whilst we're hitting our targets for the first half of the year, for the second half of the year, I'll keep bringing updates as we get them and move them forward. But final thing just to pick up on, and James alluded to it in terms of our banking agency. We are continuing to be heavily reliant on banking agency as a trust, and as a result, we are exceeding our agency ceiling targets that we have issued from NHS Improvement. This isn't being monitored this year because nationally most organisations are having the same impact really. So it's just a point to note that we are continuing to be heavily reliant on banking agency, and it does come at a premium cost, which, linking back to the recruitment and retention section that Jane was just updating us with, if we can get that right, we can see some real cost savings come out of that. So happy to take any questions on those final sections or the rest of the report, but thank you very much, Chair.
Thank you, Mark, and apologies again to you and Jane for cutting you both off in your prime, getting carried away with myself. Anita, you have a comment.
I did, and it relates to the two safe staffing tables, and it's really just for board's information. I've added more information into the IPR this month than we do normally. I'm conscious that we obviously have yourself, Kevin, that's new, and new non-executive directors, but I wanted just for people to be able to see the detail that we look at. This won't all be in every month, but I think it's important when we talk about kind of banking agency, you know, I obviously have to consider the quality of care too. So the final column, which talks about how many shifts we've covered by how many people, we do try and block book, and we don't get a lot of kind of just random one-off shifts. And I think the narrative in there explains that. But just one other comment, that the 6-month detailed safe staffing review is due to come to board in November. We are lucky that we have one of 5 of the gurus in the country really who really understand the tool, the evidence-based tool that is out there. And she is going to run a dedicated session for executive team and non-executive members at the end of September, October, ahead of that report coming, which will help us with some of the clarity around some of the questions and issues that were raised at the last report. So we will have a dedicated session on the safe staffing and the reporting ahead of the next review. I just wanted to let people know. Thank you.
Thanks, Anita. Any other questions or comments for Jane? I recognise, Jane, absolutely the importance of the work on recruitment, as we referred to earlier, particularly the foreign national recruitment, and there is a clear mechanism for continuing to provide oversight and governance of that through people and sustainability committees. So that's the source of the board's assurance that we're staying on track with all of that. So I'm grateful. Thank you very much. If there are no more questions or comments, then I can move on to you, Peter.
Thank you, Chair. So it's the board assurance framework. The board will have had opportunity to see this, and in fact through each of its committees, because the assurance framework is now made up of 3 sections from each of the committees. Just very briefly, we've been developing the new methodology and format since our board development session in February, and picking up further recommendations from our internal audit in May. So this report is now beginning to shape and look exactly as per the board and internal audit recommendations. You'll see for the first time we've now cross-referenced into it all of the risk register risks, with the numbers shown under the risk column. We have got more to do, and this will be part of that discussion in August at the board development session, where we'll be looking at IPR, risk and assurance all together as one piece of work. Just in terms of the actual assurance then the board can take from the framework, with one exception, which I'll come back to, every identified risk of delivery against the strategic objectives has got assurance against it. The level of assurance is either partial with need for some further improvement or significant. So the risks are there, they're all set out. The one area where we're currently saying that we lack assurance is in the area around the system and system improvement, and that's largely around there's a lot of unknowns, and the process and governance of that is also not quite clear yet. So that's why the assurance is currently lacking there, and I know that Sustainability Committee will be picking that up in their next meeting in a couple of weeks' time. So short of picking out any other individual risks, I'm just happy to leave it there. That's probably worth also pointing out we've also now identified each of the the actual sources of assurance we flagged, whether they're internal or external, which again was an audit recommendation. So happy to try and address any comments or questions.
Thank you, Peter. So I guess the key question is for the board is do we take the right level of assurance from the BAF that we need to be able to be confident of our assurance framework? I've used too many assurances in one sentence, but you know what I mean. And the only one, as you say, that stands out is the wider system piece, but there are a number of moving parts with that at the moment that makes it difficult to pin that down. But my sense is that we've got a solid level of assurance across the framework. But I invite comments or questions from colleagues. There are none, so I think we can safely assume, Peter, that the board is content with the assurances that you've presented and don't require any other actions to get to that stage, other than, as you say, around the wider system piece. So let's move on then to item 8.1, which is also yours, Peter.
Yeah, I'll move on, Kevin. If I could just point out for the record, because public record won't see this in the chat bar, the Chair of Audit Committee has also just confirmed.
Very well spotted, thank you.
The Chair of Audit Committee saying it agrees with your assessment, Chair, and Di is also confirming she's happy with the assurance. Yeah, moving on to the forward programme for the board. The two separate documents here. The first is the imminent and up and coming meetings. Just to flag that for all of the imminent up and coming meetings, including the board development session, we are remaining in virtual meeting, so that we are setting the example for the most risk averse actions in relation to COVID. All of the meetings are there, they're set up, and this the document simply provides the board with a calendar check. So it'd be grateful if board members could just check their personal calendars against that list. And then perhaps more significantly, we've got the table for the pre-planning for the 2022 meetings. This sets out a programme for the whole year of each of the board, council and committee meetings. Just a few very quick highlights. We've retained the pattern of 8 board meetings and four development sessions in the year. We have moved the Council of Governors meeting dates to follow the board on all but one occasion, which is in April next year, where it will be before the board, but that is for a particular purpose, which is we will have a non-executive director appointment to make at that time, and it fits that time frame for doing that. So we've moved this around. There may need to be some tweaks to the proposed dates for the Governor's Representation Committee. That's just to space it a bit better. But other than that, we'd like the board's approval to go ahead with this, because once we start getting this into shape, it commits us to lots of governance structure, and as well as thinking about the well-being and welfare of all of the directors, also allows for things like holiday planning and things to go ahead in an appropriate time frame.
Grateful, thank you, Peter. Any comments or questions on that schedule of work? No, there are none.
Okay.
Thank you, Peter.
Do you want me just to keep on a roll?
Yeah, you keep on a roll, please.
Okay, so the next item is the annual review of the standing financial instructions and scheme of delegation. These are huge documents. I'm grateful to Michelle Tolan in finance, who helps me each year to do the annual review of them. We've conducted the annual review. It's been to audit committee, who are satisfied that we have picked up the necessary areas. If I could just flag one area that perhaps isn't mentioned in the report, we have left within the standing financial instructions the annual quality reports. Board will be aware that they have changed significantly over the last 2 years, and there is some question as to whether they will be required in that format going forward. However, until we've got definitive guidance from NHS England, we have left it in. That is one thing we may, although it's in SFIs, we may vary from them and not produce if they're not required. Other than that, the revised SFIs, they're all marked up. They show where we've made changes, and we need the board to approve both the SFIs and the scheme of delegation. Thank you.
Okay. Any questions or comments for Peter? If there aren't, I would be grateful if colleagues could signal their approval of the SFIs and scheme of delegation, please. Yep, you have approval for those, Peter. Thank you very much.
Thank you. And then the final document then is the speaking up procedure. This procedure, as you heard Sarah reference earlier when she did the speaking up annual report, had some minor amendments made to it as part of a lessons learnt exercise earlier in the year. As you know, we receive feedback from people who do speak up, and there was a recommendation that we were clearer about the options and routes that could be followed, because the previous report did rather, previous procedure did rather imply that everything would be formally and fully investigated, whereas in fact that's just one of the options. There are many other options around mediation and review, putting things right, not the right word. So the procedure is slightly amended. It's been through audit committee and it's recommended for approval. We also at the same time did include a new route in there to go via safeguarding.
Thank you, Peter. Grateful if colleagues could indicate whether or not they're happy with the proposed changes to the procedure. Yep, I'm seeing lots of yeses and nothing to the contrary, so you can take it that that's approved. Thank you, Peter.
Thank you. And then Kevin, I'll just say for the last, I know you've got any other business to do, but while I'm speaking, I'll just say from a self-certification point of view, there's nothing that's come up in the meeting today that would indicate needing to be reported to a regulator.
Thank you. I'm grateful for that. I'm going to do any other business. I've got one item of other business. I've not been notified of any others. My one item of other business is to note with some sadness, I have to say that this is Hugh's last public board meeting, and I just want to put on the record the board and the trust's appreciation of your service to the trust, Hugh, and your contribution during your time as a non-exec. I think we might have a little bit more to say at the end of our private session, but for public consumption and for the public record, I'd just like to say on behalf of the board that we're sad to see you go and very, very grateful for your contribution.
Thank you very much, Chair. Appreciate your comments, and it's been a pleasure to work with colleagues, executives as well as the non-executives. Thank you very much.
Thank you. I intend to close the meeting at that point because I'm really conscious of time. We have a private session to move into after this, and I'd like to give people a chance to have a meaningful break between the two. My proposal is that we should take 25 minutes and reconvene a little bit later than planned at 1 o'clock and try and do our business after lunch in as purposeful a way as we can. Thanks very much, everyone.
Thank you.
Thank you.
Thank you.
Thanks, Kevin.